What's going on, besties? This is the comprehensive ECG concepts guide showing you everything you're going to need to know in order to ace those ECG exams. Let's get started. So we're going to start by talking about the distinct segments you're going to see on an electrocardiogram. So we're going to start by talking about our isoelectric line, which is this black line that runs through our ECG. This line acts as a critical baseline, representing the moment when the heart's electrical activity shows no net movement, effectively a zero electrical potential state. This baseline is essential for interpreting the heart's electrical signals accurately, allowing healthcare professionals, like you, to distinguish between the various phases of the heart's activity, such as depolarization and repolarization cycles. It aids in identifying abnormalities in heart function by highlighting deviations from normal heart rhythm patterns, making it a fundamental aspect of ECG analysis. The first initial minor peak that you're going to see on your ECG is called the P wave. It then proceeds to our next prominent formation called our QRS complex, and it ultimately concludes at the next subsequent minor peak, which is known as our T wave. We're going to explore each of these in detail, starting with our P wave. The P wave is going to signify atrial depolarization, also known as atrial contraction. It's a phase where the two atria are ultimately going to contract together. And following that, we have the QRS complex, which is known as our ventricular depolarization, which is when our ventricles are going to contract together. Essentially, depolarization is just a fancy way of saying contraction. But how can we differentiate between the two? Well, the P wave is linked to the atrial activity, while the QRS complex relates to our ventricular activity. A helpful hint if you're getting confused between the two, the QRS complex represents an inverted V, with the V representing our ventricles. And lastly, we have the T wave. So the T wave is going to represent ventricular repolarization. This is marking the period where the ventricles are beginning their process of relaxing. It's essential to remember that each depolarization phase, which leads to contraction, is invariably followed by a repolarization phase, allowing for relaxation. So this always brings up an intriguing question. Where does the atrial repolarization occur? If the QRS complex is associated with ventricular depolarization and the T wave is associated with ventricular repolarization, then atrial repolarization must occur somewhere between that, right? Indeed, atrial repolarization happens concurrently within the time frame of the QRS complex. The QRS complex, being a pronounced structure, overshadows atrial repolarization. And this is because the ventricles contract with much more force than we see with the atria, effectively concealing that atrial repolarization signal. Therefore, atrial repolarization leading to the atria's relaxation occurs following the P wave but is encompassed inside the span of our QRS complex. Next, let's talk about segments and intervals. Located between our P wave and the QRS complex, we have the PR segment, which illustrates the delay introduced by the AV node. This delay, orchestrated by the AV node's role as the gatekeeper, allowing the atria sufficient time to transfer blood into the ventricles before those ventricles begin to contract. Within the same region, we can identify the PR interval, which is a critical measurement at the start of the onset of our P wave, and it continues up until the start of our QRS complex. Understanding and measuring the PR interval is vital when we're diagnosing conditions like heart blocks. Next, we have the ST segment, and this marks the end of ventricular depolarization and the onset of ventricular repolarization. It is expected to be flat like in its appearance here, reflecting its isoelectric nature. This means it should appear as a straight line without any upward or downward deviations. Evaluating the ST segment is crucial because deviations from that expected flat line is going to show potentially some cardiac conditions like ischemia, as well as myocardial infarctions, which we're going to talk about in just a second. So the QT interval that we see here spans from the onset of our QRS complex to the end of our T wave, representing the duration required for the ventricles to both contract and subsequently relax in response to electrical signals. This represents an ideal ECG waveform as described in your textbooks. Yet it's important to delve into any kind of potential issues that we could see with these waveforms, segments, and intervals that we might encounter. So we're going to start with P-wave abnormalities such as peaking, notching, and inversion. They provide valuable insights on the atria's health as well as the function. So anytime we see this kind of peaking that takes place with our atria, we're looking most likely at right atrial enlargement. This is typically a result of conditions that impose increased pressure or strain on that right atrium, such as things like pulmonary hypertension. We can also see this notched kind of formation when it comes to our P wave. This is sometimes referred to as biphasic P waves, and this can indicate left atrial enlargement, pointing to issues with the mitral valve. Maybe that's disease, or we could even see hypertension that's ultimately going to affect the left side of the heart. And lastly, we may even see an inverted P wave kind of scenario. And whenever we're looking at inverted P waves, we're most likely looking at junctional rhythms. So ST segment abnormalities, specifically we're looking at either depression of that ST segment or we're looking at elevation of that ST segment. And it's critical indicators because either we have some kind of ischemia or we have some kind of infarction taking place in the heart. So an elevated ST segment is a hallmark sign whenever we're looking at an acute myocardial infarction, also known as an MI, suggesting that a portion of the heart muscle is actively undergoing damage due to a lack of blood supply. Anytime we see these kind of changes to the ST segment, especially elevation, we have to give that patient immediate medical attention to restore the blood flow and hopefully minimize the damage that the heart is taking. So in contrast, an ST depression like we see here often indicates that we have myocardial ischemia taking place, which, although not as immediately life-threatening as we see with an MI, still signifies that the heart muscle is not receiving sufficient oxygen. Ultimately, both conditions are serious and necessitate prompt evaluation and management to prevent further cardiac complications. Lastly, let's talk about deviations when it comes to our T wave. They can either be tall, inverted, or hyperacute. So anytime we see tall T waves or peaked T waves like we have here, we're most likely looking at some kind of hyperkalemia, which is an elevated potassium levels that could ultimately affect the cardiac conduction. There are also some reasons why we might see an inverted T wave. Sometimes a normal variant can also signify myocardial ischemia, previous myocardial infarction, or pericarditis, reflecting changes in myocardial repolarization. And lastly, we have hyperacute T waves where they're really high, really peaked, characterized by a broad base and peaked appearance. Maybe early indicators of some kind of acute myocardial infarction taking place, signaling the initial stages of cardiac injury. So let's take a closer look at our ECG graph paper. So this is what you're going to see on a standard ECG strip. Each strip is divided into large squares as signaled by these darker lines that you see here on your strip. And with each large square, it's going to contain 5 smaller boxes. So starting with our little purple box that we see right here, one tiny little square, one small square is equal to 0.04 seconds. Since we know that large squares are comprised of 5 of these small squares, a single large square, which we have represented right here in green, represents a total of 0.20 seconds. And expanding on this by understanding that 5 large squares are going to amount by 1 second. So as you can see here, we have 5 large squares in blue. 5 times 0.20 is going to give us 1 second. And this is ultimately going to help us with the timing of cardiac events accurately. Furthermore, whenever we say that we're looking at a 6-second strip, we're ultimately referring to a strip that has 30 large boxes. As you know, 30 large boxes multiplied by 0.20 is ultimately going to give us 6 seconds. So whenever we're looking at rhythms that are considered irregular, we can multiply the amount of R waves that we see across that entire 6-second strip by 10 to give us our full heart rate for a minute. This systemic layout is crucial for accurately measuring and timing the duration of various cardiac events, as well as identifying any potential abnormalities in our heart's rhythm. So let's talk about how we are going to identify our ECG rhythms. So here's the 6-step process that we are going to follow. So we're going to start with step 1, and we're going to identify whether the rhythm is regular or irregular. Step 2, we're going to determine the heart rate to see if it falls either in our SA node, our AV node, or our Purkinje fibers. Step 3, we're going to examine the P wave. We want to make sure that we have a P wave for every QRS complex and it has that nice upright shape. Step 4, we want to measure the PR interval and the QRS complex to make sure that these are within normal. As you know, a PR interval should be between 0.12 to 0.2 seconds, and our QRS complex should be narrow and normal, less than 0.12. Step 5, we want to look for anything that doesn't seem right. Do we have any early beats, missing beats, maybe beats that look a little bit different from the rest? And then once we have all of this information available to us, we are going to go to step 6 and we're going to interpret what that rhythm is. So starting with step 1, we want to assess whether the rhythm is regular or irregular. We determine this by measuring the spacing between our consecutive R waves. I always recommend using calipers for precision, but a simple alternative method is you can also use an index card. So what you want to do is you want to mark the distance between two R waves when you're measuring on your 6-second strip. As you're measuring down your strip, we call this marching out, these little marks should always fall in the exact same place every single time with each R wave. If that distance does match, it indicates that we have a regular rhythm. If the distance varies, that means that the rhythm is going to be called irregular. So as you can see here on our 6-second strip, if I was to measure all of these R waves using that little method, it should come out the same every single time. We call this marching out. And we would name this a regular rhythm because the spacing in between these R waves are always going to fall uniformly. However, if we were to look at a rhythm like this is an irregular rhythm. Because if I was to march out and measure in between all of these R waves, they're not going to fall the same every single time, as you can see on your screen. Some are shorter, some are longer. They're just not going to be uniform. So we would call this an irregular rhythm. So step 2 involves determining our heart rate. Before proceeding, it's crucial to make sure that we have a 6-second strip. Nursing schools, as well as sometimes when you're in the healthcare profession, you're not always given the whole strip. So it can skew your heart rate depending on how long or how short that strip is. A key way to indicate if we have a 6-second strip is to look for these little markers at the top of your ECG strip. Spotting these lines indicate that we are going to have 10 large boxes in between each marker line. You want to make sure that you have a total of 30 large boxes across in order to signify that you have a complete second strip. I want to make a quick disclaimer regarding the strips that you're going to see in the ECG video series, as many of them are not going to have 30 large boxes. But for educational purposes, we are going to assume that every strip we see is a 6-second strip. So to determine heart rate for regular rhythms, we want to count the amount of small boxes in between two consecutive R waves and then divide that total number by 1500. So if we look here, we have 1 large box, 2 large boxes, 3 large boxes in between our R waves. So we take 1500 and we divide that by 15, and that is going to give us our total heart rate of 100 beats per minute. Next, we want to determine heart rates for irregular rhythms. This process involves counting the number of R waves within our 6-second strip and then multiplying that by 10. So if we were to count our R waves, we have 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. We would take that number of R waves, we're going to multiply it by 10, and that's ultimately going to give us our heart rate of 120 beats per minute. So step 3 is the process of identifying and scrutinizing our P waves. Under normal conditions, our P wave should be visible and upright like we see here at the bottom of your screen. Whenever we have an absence, inversion, retrograde, or short P wave, it might suggest that we're looking at a junctional rhythm, indicating there's some kind of irregularity taking place in the heart's electrical activity. Next, let's assess the PR interval, which spans from the start of our P wave until the start of our QRS complex. This is achieved by tallying the small boxes between these 2 points and multiplying that by 0.04 seconds. A normal PR interval should be between 0.12 and 0.2 seconds. If we have a PR interval that's going to exceed that 0.2 seconds, it may signal some kind of dysrhythmia, such as a first-degree heart block, highlighting potential disruptions in the heart's electrical conduction system. Next up, we want to evaluate our QRS complex, and this involves the similar approach that we saw with our PR interval, which is we're going to count the number of small boxes from the start of our QRS complex to the end of our S wave. The ideal QRS duration should be between 0.06 and 0.12 seconds. I usually always ask myself whenever I'm looking at QRS complexes, are they narrow and normal or are they big, wide, and ugly? If we have a QRS complex that is big, wide, and ugly, meaning that it's greater than 0.12 seconds, the rhythm is always going to have either bundle branch or ventricular in the name. We're going to discuss this more when we get into our ventricular rhythms, but keep that in the back of your mind. Step 5 includes early beats, missing beats, or beats that just appear a little bit different from the rest. So anytime we're looking at early beats, we're most likely looking at premature contractions. They can originate from the atria, meaning that they are a premature atrial contraction. They can come from the junction, meaning that they're a premature junctional contraction, or they can originate from the ventricles, meaning they would be a premature ventricular contraction. Anytime we're looking at some kind of missing beat or pauses, it can suggest that we're looking at a delay or block in the heart's electrical system, potentially pointing to an atrioventricular block or even a sinus arrest, where the heart skips a beat or more due to the disruption of the heart's rhythm. And anytime we see beats that just look a little bit different from the rest, this could signify that we have some kind of arrhythmia taking place, like atrial fibrillation, where the P waves are absent and replaced by these kind of fibrillatory waves, or we could even be looking at ventricular tachycardia, characterized by big, wide, and ugly QRS complexes. Each of these patterns are ultimately going to provide us with vital clues of underlying heart conditions, requiring careful evaluation to determine the appropriate management and treatment options. And then our final step, step 6, we're going to interpret the rhythm. We could either be looking at a sinus rhythm, an atrial rhythm, a junctional rhythm, ventricular rhythm, lethal rhythm, heart blocks, or we could even have a patient that has a pacemaker. So stay tuned, those videos are going to be coming to help you identify those individual rhythms. Normal sinus rhythms is the most common cardiac rhythm that you're going to see, and typically it's observed in healthy individuals on a daily basis. Its heart rate should be between 60 to 100 beats per minute. This kind of rhythm indicates that sinoatrial node is functioning as the primary pacemaker. The assumption here is that the SA node is initiating the atrial depolarization under normal conditions. For a rhythm to be classified as normal sinus, it must maintain a regular pattern, known as regularly regular. And this is verified by the measurement of our R to R segments. So using calipers or a piece of paper, you can mark and measure from the start of one R wave to the next R wave, and then continue that measurement all the way down your 6-second strip to ensure that there's consistency between each R wave interval. Although slight variations over time are normal, abrupt changes from beat to beat indicate that we have some kind of irregularity. Additionally, for a rhythm to be considered sinus, P waves must be present with a consistent P to QRS ratio of 1:1. That means each P wave must be followed by a QRS complex all the way down our 6-second strip. It should be synchronized as well as orderly. Another thing is that our P wave needs to be upright from our isoelectric line. So remember, we talked about that imaginary line that runs through our strip. If we see any variations in that P wave's appearance, then we're probably looking at a different kind of rhythm. Next up, our PR interval should be normal, ranging anywhere from 0.12 to 0.20 seconds, which corresponds to the width of about 3 to 5 small boxes. Additionally, our QRS complex needs to be narrow and normal, which means it needs to be less than 0.05 0.12 seconds. If our QRS complex does exceed the width of our 3 small boxes, then we call our QRS complex big, wide, and ugly. Lastly, we should not see any early beats or missing beats. This rhythm really is textbook, and it describes what we should see when it comes to a standard, healthy heart rhythm. It typically presents with no signs or symptoms, and it doesn't require any interventions or treatment. Such a rhythm indicates the heart is functioning appropriately, efficiently circulating blood throughout the body without any disturbances. So sinus bradycardia mirrors normal sinus rhythms in every aspect except when it comes to the heart rate. In sinus bradycardia, the rate is less than 60 beats per minute. Apart from the slower rate, all other characteristics align with a normal sinus rhythm. The rhythm remains regularly regular. Our P wave is going to be present before each QRS complex and upright. Our PR interval and our QRS complex should remain within normal, and we're not going to see any abnormal beats. By meeting these criteria, we can confirm that a diagnosis of sinus bradycardia is present, distinguished by that reduced heart rate. So what's interesting is that sinus bradycardia can be normal in some healthy individuals, especially athletes due to their enhanced cardiovascular efficiency. However, it can also arise from various pathological conditions or external factors. Additional causes can include sick sinus syndrome, myocardial infarction, and the effects of certain types of drugs and toxins, like we see with calcium channel blockers, beta blockers, and digoxin. We may also see environmental factors such as hypothermia or even hypoglycemia. Not every person who experiences this rhythm is going to be symptomatic. However, if they are symptomatic, they might experience things like a slow pulse rate, episodes of syncope or near syncope, fatigue, dizziness, lightheadedness, shortness of breath, confusion, or even chest pain. These symptoms, particularly when they are severe, can diminish quality of life and hinder physical activity. So when it comes to treatment, it's really dependent on how severe and what the underlying cause is. Asymptomatic and mild cases may not require treatment, while more severe instances follow the Advanced Cardiac Life Support (ACLS) algorithm for bradycardia, which includes our first action, which would be administering atropine. We give 1 milligram every 3 to 5 minutes, up to 3 milligrams total. If atropine is ineffective, you may see transcutaneous pacing, which are just pads that are put on the patient while they're awake to help maintain the heart rhythm. As always, this is really uncomfortable, so make sure that you give them some pain medication so that they can tolerate it. You may see additional things like dopamine and epinephrine infusions in case we need to again manage and stabilize that heart rate if all else fails. So next up we have sinus tachycardia, and that is defined primarily by the heart rate exceeding 100 beats per minute. It's important to note that if the heart rate exceeds 150 beats per minute, we're looking at something else. This is not a sinus tachycardia. Think of something else. For instance, our ECG rhythm strip that we have here is about 120 beats per minute. I'm simply just going to count the R waves. We have 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. So 12 times 10, it gives us 120 beats per minute. As we learned in our previous video, typically we divide the total amount of small boxes by 1500 in order to find our heart rate. However, we will make it easier when it comes to education about how to identify these rhythms by adding up the total R waves and multiplying it by 10. So let's talk about some important characteristics. Again, the rhythm is going to be regularly regular. Our P waves, we're going to have a P wave before every QRS complex, and they also should be upright from our isoelectric line. Our PR interval and our QRS complex should remain within normal, and of course, we should not see any abnormal beats when it comes to this rhythm. Causes typically arise from the compensatory response to bodily conditions like decreased volume as well as catecholamine response due to stress. You may even see medications being an issue, which could be caffeine, nicotine, any kind of illicit drugs like we see with cocaine and methamphetamines, anticholinergics, as well as beta blocker withdrawal. Signs and symptoms typically remain the same like we see in sinus bradycardia, except in this instance we're going to see a rapid pulse rate. So with sinus tachycardia, we don't usually move into the immediate advanced interventions with these kind of rhythms. Often simple measures like fluid administration can effectively manage this condition. Next up, we have sinus arrhythmia, particularly respiratory sinus arrhythmia, which is a natural variation of the heart rate that occurs during the breathing cycle. This particular rhythm is more pronounced in children and most commonly seen in young, healthy individuals, and is generally considered normal, reflecting the heart's ability to adapt to changes in physiological demands. So when the lungs inhale, the diaphragm contracts and it pulls downward. At the same time, the muscles between the ribs contract and pull upwards. This ultimately increases the size of the thoracic cavity and decreases the pressure found inside. Because of this, the heart rate is going to increase, allowing more blood to flow back to the heart from the veins, increasing our venous return. Conversely, during exhalation, right, the heart rate is going to slow down. As you exhale, the pressure in the chest is going to slightly increase. Venous return to the heart is going to decrease, and the heart doesn't have to beat as quickly. So the autonomic nervous system regulates this process through the vagus nerve, which controls heart rate among other functions. During inhalation, that vagal nerve, our parasympathetic activity, is going to decrease, which speeds up the heart rate. During exhalation, that vagal activity is going to increase, which is going to slow down the heart rate. It's important to remember that our vagus nerve follows that parasympathetic pathway, which is our rest and digest. So it's going to do the opposite depending on if it is being stimulated or not. This modulation helps optimize gas exchange during respiration. It's going to improve heart efficiency and is an indicator of a healthy cardiovascular system. So the heart rate typically falls within the normal range of 60 to 100 beats per minute. So if we were to count this 6-second strip, we would have 1, 2, 3, 4, 5, 6, 7. We have about 70 beats per minute. And just like with normal sinus rhythms, our P wave is going to be upright in our isoelectric line, and it's going to be before every QRS complex. Our PR interval as well as our QRS complex should be within normal, and we're not going to see any abnormal beats. Despite these consistencies, the rhythm shows noticeable variability. Measurements between beats may appear regular at some points, but then show prolongation, creating a pattern that fluctuates slightly. Since sinus arrhythmia is typically a benign and physiological response, it doesn't usually require any kind of treatment. However, the approach may vary slightly if the patient is symptomatic or linked to any kind of underlying conditions. We're most likely going to monitor the patient. We want to address any kind of underlying condition, and we may even advise some kind of lifestyle adjustment. For those who may experience discomfort or anxiety, we might talk to them about relaxation techniques. Stress management, as well as ensuring adequate hydration, may also be a recommendation for these kinds of patients. And then lastly, we have sinus pause, which is also known as sinus arrest, because it disrupts what would otherwise be a normal sinus rhythm. In some cases, you'll notice a significant interruption in the rhythm. Essentially, you're going to notice a gap in between some of your P and QRS complexes. I like to think of it as we've been ghosted by one of our complete complexes. During a sinus pause, the heart rhythm is regular and becomes variable due to that interruption in the conduction system. The P waves are typically present except during the pause, which defines the nature of the sinus arrest. If a P wave is present without interruption, then we're probably looking at something else that does not qualify it as a sinus pause or arrest. So what I mean is to say is that if we had a P wave here with no QRS complex behind it, we're probably looking at a different kind of rhythm. Despite these abnormalities, the PR interval is going to remain within normal limits, and the QRS complex width is going to be narrow and normal. This rhythm can be caused by a number of reasons. The autonomic nervous system, which controls involuntary bodily functions, including our heart rate, can cause excessive stimulation when it comes to our vagus nerve, leading to a decrease in that SA node impulse generation. This is often seen in response to physiological stimuli such as gagging, vomiting, or intense emotional stress. If you've ever taken care of a patient who was straining for a long period of time on the toilet and they suddenly just passed out, you may see a sinus pause or sinus arrest when you're looking at the monitor. So when we talk about intrinsic SA node dysfunction, we're talking about the SA node maybe having some kind of intrinsic abnormalities due to aging, ischemic damage, inflammatory respiratory conditions, or even degenerative diseases that can ultimately affect the generation of regular impulses. Again, certain medications, particularly those affecting heart rate and rhythm, such as beta blockers, calcium channel blockers, and antiarrhythmics, can suppress the SA node's pacemaker activity. We may also see imbalances of key electrolytes that regulate heart function, such as potassium as well as calcium. They can ultimately impair the electrical activity of the SA node. Other causes can include hypoxia as well as increased vagal tone. Sinus pause or arrest can manifest through various signs and symptoms, such as palpitations, dizziness, lightheadedness due to reduced cardiac output. We may even see syncope if the pause is prolonged, occasional fatigue, and in older adults, we can see confusion or memory issues from transient reduction in the cerebral blood flow. And on rare occasions, ischemic-related chest pain may occur. Treatment for sinus pause or arrest aims to address its underlying causes as well as the severity. In some cases, we may need to adjust medications, depending on if that's the cause, and in other cases, we may have to implant a permanent pacemaker if we see repeating episodes. So let's do some practice on identifying these rhythms. So first up, we have the following rhythm. We want to look to see if the rhythm is regular or irregular. So we're going to measure between each R wave, and just by doing just a quick glance at this, it looks like this rhythm is actually going to be regular. Next up, we want to see the heart rate. So typically what we want to do whenever we have a regular rhythm is we want to count the number of small boxes in between each R to R segment and then divide that by 1500. But in order to save us just a little bit of time, I'm going to go ahead and count them. So we have 1, 2, 3, 4, 5, 6, 7, 8. So we have approximately 80 beats per minute. Next up, we want to look at our P wave. So do we have a P wave present before each QRS complex, and are they upright? So if we take a look, this one's good. We get a QRS, upright QRS, so on and so forth, all the way down our 6-second strip. So we can say that this follows that 1-to-1 ratio. So next up, we want to measure our PR interval and our QRS complex. So I do this by counting the small boxes. So we're going to start right here at the beginning of our P wave until right here before our QRS complex in order to get our PR interval. So we have 1, 2, 3, 4, like 4.5 boxes here. So 4.5 boxes multiplied by 0.04 is going to give us 0.18 seconds, which is still normal for our PR interval. Next up, we're going to measure our QRS complex. So again, we're going to start at the beginning of our QRS until right about here at the end of our QRS. So we have about 1, maybe 1.5 boxes for our QRS complex. So 1.5 boxes times 0.04 is going to give us 0.06, leading us to believe that we have a narrow and normal QRS complex. And then lastly, we want to look to see if we have any abnormal beats. So based on looking at our 6-second strip, I don't see anything that's abnormal, so we can go ahead and put none in that category. So based on our 6-step process that we have whenever it comes to identifying underlying rhythms, we can see here that all of this criteria meets our normal sinus rhythm, meaning that we have a normal sinus rhythm. So we're going to move a little bit faster. Let's take a look at our next rhythm. So starting with our rhythm, if we were to measure from our R to R complex, it looks pretty regular here as I can see. So we're going to go ahead and call this rhythm regular. Now we need to look at our heart rate. So if we count that, we got 1, 2, 3, 4. So our heart rate is approximately 40 beats per minute. Do we have a P wave before every QRS? This one's a little bit hard to see because it's off the screen, but as we can see here, P wave, QRS, P wave, QRS, P wave, QRS. Yep. We absolutely do. So we do have a 1-to-1 ratio. Now we need to look at our PR interval and our QRS complex. So as we can see here, we have approximately from here, we got 1, 2, 3, 4, 5 little boxes. So 0.04 times 5 boxes is going to give us 0.2 seconds. So now we want to take a look at our QRS complex. So what do we have going on here? So we have about 1.5 boxes that I can see. So 0.04 times 1.5 boxes gives us 0.06 seconds. And lastly, we want to look to see if we have any abnormal beats. Based on everything that I can see here, everything's pretty consistent, so we can go ahead and say that there are none. So out of everything I can see, everything's pretty much normal, except right here, our heart rate is a little bit slow, right? We know with our sinus rhythms, they should be between 60 to 100 beats per minute in order for them to be regular, normal sinus rhythms. So here, this one's a little bit slow, so we know that we're dealing with a sinus bradycardia simply based on the fact that we have a heart rate of 40 beats per minute. Taking a look at our next strip, we can see that this one's a little bit fast, right? But if we were to measure in between each R to R complex, it pretty much remains consistent all the way through. So we can call this rhythm regular. Now we need to figure out the heart rate. So again, I'm just going to count here. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13. So we have a heart rate of approximately 130 beats per minute. Do we have a P wave for every QRS complex, and is our P wave always upright? We most certainly do. We have an upright P wave, QRS, upright P wave, QRS, so on and so forth, all the way down to the line. So we have a 1-to-1 ratio when it comes to our P waves. Next up, we want to measure our PR interval and our QRS complex. So taking a look at this, our PR interval looks like it's approximately 1, 2, 3-ish boxes. So we have 3 boxes times 0.04, and that gives us 0.12 seconds. That's still in normal. And now we want to look at our QRS complex. So we've got approximately 1, maybe 1.5 boxes. Hard to tell, but maybe 1 to 1.5. So we've got 1.5 boxes times 0.04, and that is going to give us 0.6 seconds. And then lastly, we want to take a look to see if we have any abnormal beats. Based on what we can see here, everything looks pretty regular. We don't see anything that's out of the ordinary, so we can go ahead and list none. So everything meets the sinus rhythm criteria. The only thing that's a little bit different is the fact that we have a really high heart rate. So based on our SA node, the heart rate should be between 60 to 100 beats per minute. This one's a little bit higher, but it's less than 150. So we can call this rhythm sinus tachycardia. So this rhythm looks a little bit interesting, right? So here we can see, yep, it looks pretty regular-ish, but then look, it becomes a little bit tighter, and then it becomes prolonged again. So with this kind of rhythm, we're gonna call this irregular. This is an irregular rhythm. So we wanna go ahead and count our R to R complexes. We've got 1, 2, 3, 4, 5, 6. So we got approximately 60 beats per minute. Do we have an upright P wave for every QRS complex? We absolutely do. Upright QRS, upright QRS, upright QRS, so on and so forth, all the way down. So we can say that this has a 1-to-1 ratio for sure. And then now we want to look at our PR interval in our QRS complex. So taking a look here, we've got 1, 2, 3, 4-ish boxes. So 4 boxes times 0.04 is going to give us 0.16 seconds. And then now we want to look at our QRS complex. So we've got about 1, 2, approximately 2 boxes for this one. So 2 boxes times 0.04 is going to give us 0.08 seconds for our QRS complex. And then lastly, do we have any abnormal beats? Nope, absolutely not. Everything looks normal. So here we've got something that's a little bit different, right? So we have 60 beats per minute, which means it falls within that normal sinus range. Everything else is normal except the fact that our rhythm is irregular. There's only one sinus rhythm that is irregular, and that is our sinus arrhythmia. Because as we know, our heart rate beats a little bit faster during inspiration and it slows down during expiration. So let's take a closer look at our final practice problem. So what do we have here? Well, it looks like we have something a little abnormal here, right? Something should have happened here and they didn't. Looks like we got ghosted, right? So let's take a look at the rest of the rhythm outside of this. So if we were to measure in between these two R complexes and between these two R complexes and compare them together, we would see that we actually have a regular rhythm. So now we just need to figure out what is our heart rate. So our heart rate should be, this is the time that I would absolutely use the divide by 1500 because we are missing a beat right here. So we're going to go ahead and count our boxes. So we have 1 big box, 2 big box, 3 big box, that's 15, 16, 17, 18. So we have 1500 divided by 18 is going to give us approximately 83 beats per minute. Do we have an upright P wave for every QRS complex? We absolutely do. Upright P wave, QRS, upright P wave, QRS. We have no P waves in between here. That's fantastic. Upright P wave, QRS, so on and so forth, all the way down. So we can say that we have a 1 1 ratio. Next up, we want to look at our PR interval and our QRS complex. So here we've got approximately 1, 2, 3, 4, 5 boxes. So 5 boxes times 0.04 is going to give us 0.20 seconds, which is a normal. That's fantastic. And then with our QRS complex, we have about 1.5 boxes. 1.5 times 0.04 is going to give us 0.06 seconds. So then the last thing we want to consider is there any abnormal beats? Well, yes, we absolutely have an abnormal beat here, right? Because we have this prolongation without anything that occurred here. So we have what we want to call an extended pause. So based on everything that we have here, we have what looks to be a sinus rhythm. The only issue is that we have this extended pause. And with that, we know that we're going to have a normal sinus rhythm with sinus pause. Anytime you have this kind of rhythm, whether it's a sinus pause or a rest, you always want to name the underlying rhythm. So based on the underlying rhythm, we have a regular rhythm that's 79 beats per minute that meets all this criteria. So we know that it falls within normal sinus. The only issue is this extended pause, making this a normal sinus rhythm with sinus pause. So to begin, there are common rules that we see whenever we're identifying atrial rhythms. Number one, it's going to originate within the atria. It doesn't necessarily mean that it's originating from the SA node. So that's very important to know when we're talking about these kinds of rhythms. What's also key is that our QRS complex is going to be narrow and normal. Anytime we have a rhythm that's coming at the junction or above the junction, the QRS complex should be narrow and normal. And lastly, with atrial fibrillation and atrial flutter, anytime we see rates greater than 100 beats per minute, that means we're going to call it uncontrolled. There's no such thing as atrial fibrillation tachycardia or atrial flutter tachycardia. No, we actually call it uncontrolled. So we're going to talk about the differences between controlled and uncontrolled when it comes to AFib and aflutter. So let's begin with our most commonly seen atrial rhythm known as atrial fibrillation. It's also often referred to as atrial arrhythmia, and it is a prevalent condition among many patients, especially the elderly cardiac patients that you may see. So this rhythm is characterized by our atria. These are the upper chambers of our heart. And what's happening up here is we're having this quivering or fibrillating that's happening rather than actually having a full normal depolarization. This quivering is going to lead to high rates of atrial activity, close to almost 800 times per minute, a rate that would be unsustainable for the ventricles to match. So when we're looking at P waves and atrial fibrillation, the atria do not have discrete pacemaker activities, but instead exhibit continuous, chaotic electrical activity. This often results in what we call fibrillatory waves, or sometimes a flat line where traditional P waves are absent. And because of this, there will be no P to QRS ratio. And when it comes to our PR interval, we're also going to see it be non-measurable because we don't have distinctive P waves. The good news in this is that the QRS complex is going to remain completely normal and narrow, being less than 0.12 seconds. This rhythm is also characterized by the fact that it's going to be irregular. So in normal conditions, the sinoatrial node, which is up here at the top of our heart, generates regular electrical impulses that ensure synchronized heartbeats. However, in atrial fibrillation, multiple erratic re-entry circuits within the atria fire simultaneously, overwhelming the heart's natural pacemaking capabilities. As these numerous impulses bombard our atrial ventricular node, it struggles to filter them consistently, allowing only some to pass through the ventricles at irregular intervals. This results in the ventricles responding unpredictably, manifesting as an irregular rhythm that is the hallmark sign of atrial fibrillation. So what are some of the causes when it comes to AFib? Well, it could be some numerous kinds of heart conditions. We have chronic conditions such as hypertension, heart valve disease, coronary artery disease, congenital heart defects, as well as heart failure. Other medical conditions can include thyroid imbalances, especially hyperthyroidism, sleep apnea, and other chronic conditions like diabetes and lung disease. Age is also another big factor. The risk increases for atrial fibrillation as we age. Lifestyle factors also plays a key role when it comes to this rhythm. Excessive alcohol intake, smoking, obesity, lack of physical exercise, and even those with post-surgical complications like we see with heart surgery. When it comes to signs and symptoms, they mirror a lot of other arrhythmias. You're going to see palpitations, fatigue and weakness, dizziness and lightheadedness. You can even see shortness of breath, particularly when it comes to physical activity or even at rest in some severe cases. When it comes to chest pain, this can occur essentially whenever we're seeing high heart rates. So the higher the heart rate, the more likely the patient may experience chest pain. And then lastly, we have confusion. So confusion really are transient episodes related to that decreased cerebral perfusion that takes place with this heart rhythm. What's important to note is that patients may be asymptomatic a majority of the time. With atrial fibrillation, it's only really discovered through physical examinations or ECGs conducted for many various reasons. So how are we going to treat this condition? Treatment strategies for atrial fibrillation is going to focus on rate control, rhythm control, and stroke prevention. So when we talk about rate control, we may see medications being given like beta blockers, calcium channel blockers may also be used to control the heart rate. With rhythm control, medications to restore that normal heart rhythm, also known as antiarrhythmics, or procedures like electrical cardioversions may take place. Cardioversions is when we shock the heart back into its normal rhythm. So with stroke prevention, due to that high risk of blood being clotted up in those atria, you're going to see patients on anticoagulants, also known as blood thinners, like warfarin or newer agents that may be prescribed. If all else fails, we could see catheter ablation, which is a procedure that destroys the area of the heart tissue that is causing the irregular signals. Next up, we have atrial flutter, which is a specific type of tachycardia known as re-entry tachycardia, characterized by the rapid circulation of electrical impulses within our atria. Typically, the atrial rate when it comes to flutter can range anywhere between 250 to 350 times per minute, which is exceptionally fast and unsustainable for normal life functions. However, not all of these impulses are going to be transmitted to the ventricles. The ventricles usually conduct at a slower rate due to that atrioventricular node's capacity to filter out many of those atrial impulses. Due to the AV node's gatekeeping, the rhythm can be regular or irregular depending on when the electricity can get through to the ventricles. The atrial rhythm in flutter is generally regular, and instead of the typical P waves that you would see on regular rhythms, there's actually going to be this distinct sawtooth pattern that you're going to see before the QRS complex. These are known as F waves. The atrioventricular conduction ratio can vary. Most commonly, you might see a 2-to-1 ratio, meaning that we have 2 atrial flutter waves occurring before each QRS complex, effectively halving our ventricular response rate compared to that of our atrial rate. So for instance, if our atrial rate is 300 beats per minute in a 2-to-1 flutter ratio, the resulting ventricular rate would be approximately 150 beats per minute. What's also important to note is, as we discussed with atrial fibrillation, we're also going to see that same variation when it comes to our heart rate with atrial flutter. Anytime we have a heart rate less than 100, we call that a controlled heart rate. And anytime we see heart rates greater than 100, we call that uncontrolled. And then lastly, the signs, symptoms, and causes, as well as treatment, are going to mimic what we see with atrial fibrillation. So let's discuss our last atrial rhythm, known as narrow complex supraventricular tachycardia, which is characterized by a rapid heart rate that originates from above the ventricles, hence the name supraventricular. It's characterized by a heart rate typically exceeding 150 beats per minute with a narrow QRS complex, usually less than 0.12 seconds. What's interesting about this rhythm is that it involves the atria and the connections in the atrioventricular node, and it does not initially involve the ventricles. During SVT, the electrical signals in the heart's upper chambers misfire, causing a significantly faster heartbeat due to this enormous amount of signals that are getting through to the ventricles. So when it comes to the rhythm is going to be regular even though it's abnormally fast. Our heart rate is going to be greater than 150 beats per minute. You can even see it almost upwards of 250 beats per minute. When it comes to our P waves, that ventricular rate is going to be too fast for us to even see our P waves taking place. Know that they are taking place, they're just being hidden inside of our ECG. And because we don't have P waves, we're not going to have a measurable PR interval. And like we discussed before, that QRS complex is going to be narrow and normal. It's going to be less than 0.12 seconds. Remember, anytime we have a rhythm that is originating either at the junction, which is right here in between our atria and our ventricles, or above, we're going to see a QRS complex that is narrow and normal. So what are some of the causes that we're going to see behind SVT? Well, we could see structural heart disease. Anytime we have some kind of underlying heart condition, it can ultimately predispose us to having SVT. You can also see electrolyte imbalances, particularly abnormalities when it comes to potassium and magnesium levels. Excessive caffeine and alcohol intake can actually exacerbate or trigger these episodes. The same thing goes when it comes to stress. Emotional and physical stress can initiate SVT. And then lastly, some individuals just have a genetic predisposition when it comes to SVT. There's a lot of different genetic factors that can ultimately lead to the development of SVT. Signs and symptoms are pretty much going to remain the same like we see with all heart rhythms. The only difference is that we could see syncope and we could see anxiety. So in case you didn't know, syncope is episodes of fainting or near fainting that can occur due to prolonged SVT. And as you can imagine, feeling that beating and that rhythm inside your chest that's just you can't control, that could lead to some tremendous anxiety. So how are we going to treat this kind of condition? Well, when it comes to the treatment of SVT, we aim to slow the heart rate, restore the normal rhythm, and address the underlying cause. One of the treatment options we can see is vagal maneuvers. We do this through Valsalva maneuver, which is an attempt to breathe out forcefully when you have your nostrils and your mouth closed. This can sometimes stop the episode by stimulating that vagus nerve, which helps control the heart rate. We may also see medications taking place like antiarrhythmic drugs or even beta blockers to help control the heart rate and even prevent future episodes from taking place. Electrical cardioversions are great, especially in cases of emergencies. What happens is there's a controlled shock that's provided to the heart, which ultimately can help reset it into its normal rhythm. And then lastly, as we discussed before, we may see a catheter ablation take place, which is often a permanent solution where a pathway that's causing that SVT from taking place is destroyed by radio frequency energy. So let's do some practice. So we begin by identifying our rhythm. Is it regular or irregular? So if I was to measure out my R complexes, you're going to see that they don't fall in the same place every single time. Some are longer, some are shorter. So we can absolutely identify this as an irregular rhythm. And because it's irregular, we're just going to count our QRS complexes. So we have 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. So we have a total of 12, meaning that we have a heart rate of 120 beats per minute. Next up, do we have any identifiable P waves? As you can see here, we just kind of have these fibrillatory lines. So absolutely, we do not have any P waves that we are able to measure. And because we don't have any P waves that we can measure, that means we also don't have a PR interval. Next, taking a look at our QRS complexes, we can see that these QRS complexes are very, very narrow. So we can absolutely say with certainty that these QRS complexes are going to be less than 0.12 seconds. And do we have any abnormal beats? We absolutely do not. So based on everything that we see up here, being that we have an irregular rhythm, we have no P waves, no PR interval, and we have a narrow QRS complex, we can say with certainty that this is called atrial fibrillation. The big key here that I want you to take away is that you always have to say whether it's controlled or uncontrolled. So in this case, because we have a heart rate that's 120 beats per minute, we can absolutely call this rhythm an uncontrolled atrial fibrillation. So let's take a look at our next practice. So with our rhythm, is it regular or irregular? If I was to march these out, you're going to see that they're going to kind of fall in the exact same place every single time. So we can absolutely call this rhythm regular. When it comes to my heart rate, I'm going to go ahead and count that out. 1, 2, 3, 4, 5, 6, 7. So we have approximately 70 beats per minute. Next up, we're taking a look at our P waves. As you can see here, we actually have a couple of extra P waves that we didn't originally encounter right before in our other rhythm. So in this case, we're going to have a 2 to 1 P wave, and these are also going to be known as F waves. Because of the presence of F waves, we're not going to have a measurable PRI interval. So we can go ahead and skip over that. And if we take a look at our QRS complexes, these look very narrow, they look very normal. So we can absolutely say with certainty that these are less than 0.12 seconds. And then are there any abnormal beats? Based on what I'm seeing here, there are no abnormal beats. So what kind of rhythm do we have? You are absolutely correct. The correct rhythm is atrial flutter, but again, it's very important that we call it either controlled or uncontrolled. Being that we have a heart rate of 70 beats per minute, that means it's less than 100 beats per minute, we can call this controlled atrial flutter. So let's take a look at our last practice question. So we start by identifying our rhythm. Is it regular or irregular? Based on what I'm seeing, if I was to measure this out, the QRS complex always falls in the same place. So we can call this rhythm regular. Next up, we count how many QRS complex we have. We have 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, and 16. So we have approximately 160 beats per minute. So do we see any P waves? Well, what's happening here is that ventricular rate is happening at such a fast rate that we're not going to be able to see distinguishable P waves when it comes to this rhythm. So no, we do not have any P waves, and because we don't have P waves, we're also not going to be able to measure our PR interval. So is our QRS complex narrow and normal or big, wide, and ugly? In this case, it's very, very narrow, right? We're able to see that it's going to be less than 0.12 seconds. And do we have any abnormal beats? Absolutely not. I don't see any premature beats. I don't see anything that would be abnormal. So what kind of rhythm do we have here? You are absolutely correct. The correct rhythm is a narrow complex supraventricular tachycardia. So we always begin by talking about our junctional rules. It's important to note that the impulse that initiates the heartbeat is going to start in the AV node itself, and it only travels downwards towards our ventricles. Because the rhythm is originating at or above the junction, we're still going to see a normal and narrow QRS complex. But what's interesting here is that the intrinsic rate is going to be a little bit different. Remember we talked about the SA node and the AV node, they both have their own set of intrinsic rates. So the AV node has an intrinsic rate of 40 to 60 beats per minute. This is going to be really big when we're talking about these junctional rhythms. What's really important to note is that P wave must meet one of 4 criteria in order for it to be deemed a true junctional rhythm. And we use the mnemonic errors to help us remember that. The A stands for absent, the I stands for inverted, the R stands for retrograde, and the S stands for short. Starting with our A for absent P waves, this occurs because the impulse doesn't travel back up towards the atria. So no P wave is going to be formed in the ECG before the QRS complex, as the atria are not activated before our ventricles. And then next up we have inverted P waves. So in some cases, an electrical impulse can get through, and it's going to travel back up into our atria. We call this retrograde conduction. This backwards movement causes that P wave to appear inverted on our ECG because the electrical vectors are moving from the bottom of the atria upwards rather than the top of our atria down. And then next up we have our retrograde P wave, and this is when the P wave is visible following our QRS complex. This indicates that the atrias are contracting after the ventricles do due to the impulse traveling backwards later. And then lastly we have short PR intervals. This happens because the impulse originates near or within that atrial ventricular node and has a very short distance that it has to travel in order to reach the ventricles compared to an impulse that originates from our SA node. So that's when you're going to see basically this hugging of our P wave to the QRS. Just to review, the junctional rhythm is a type of cardiac arrhythmia where the heart's primary pacing responsibility shifts from that sinoatrial node to the atrial ventricular node or the surrounding tissue. This ultimately occurs when that sinoatrial node fails to initiate the heartbeat, or the impulse is blocked somewhere along the pathway, prompting that atrial ventricular node to take over. This backup system helps maintain a heartbeat, but at a different rate and rhythm than our normal sinus rhythms. So what are we going to see with junctional rhythms? Well, to begin with, we're going to see a rhythm that is regular. Next, we're going to have a rate that's a little bit slower because of where it originates from. Remember, we talked about before, the sinoatrial node usually typically has a heartbeat between 60 to 100 beats per minute, while our atrial ventricular node has a heartbeat between 40 and 60 beats per minute. P waves are either going to be absent, inverted, retrograde, or short in order for them to qualify as a junctional rhythm. The PR interval, if it is present, the P wave may have a short PR interval, meaning that it's going to be less than 0.12 seconds, or the interval is just not going to exist. And as we said before, anytime we have a rhythm that originates from the junction, we are going to see a normal and narrow QRS complex. Remember, if we see a big, wide, and ugly QRS complex, then we're most likely looking at something else. So let's talk about the causes as to why this occurs. One of the things could be is that there's an SA node dysfunction, and that's the failure of the SA node to generate an impulse, or there's some kind of blockage taking place that's not allowing that impulse to exit the SA node. We can also see enhanced AV automaticity, meaning that that AV node increases its intrinsic pacemaker activity. As always, there could be medications that are causing this. You could see things like digitalis, beta blockers, calcium channel blockers that are ultimately going to suppress that SA node activity from taking place, or it's going to enhance the AV nodal activity. Having previously worked as a CV-ICU nurse, this is very common with our cardiac surgery patients. A lot of times when we have post-operative complications, it's going to interfere with the normal electrical conduction systems of our heart. And then lastly, we could see it with myocardial infarction due to the damage that's taking place to the heart tissues, ultimately affecting the conduction system. As always, you're going to see a lot of the same signs and symptoms. You're going to see palpitations due to the abnormal heart rhythm. The patient could be fatigued from reduced cardiac output if their rate is particularly slower. We could see dizziness and lightheadedness related to that decreased blood flow to the brain, shortness of breath, especially when the patient is exerting themselves. And then lastly, syncope. Fading spells could occur with severe cases and significant bradycardias. So how are we going to treat this particular rhythm? Well, treatment for junctional rhythms are always going to focus on addressing the underlying condition that's causing it. We also want to make sure that we're monitoring these patients. Asymptomatic patients or those with benign causes might only require minimal observation when it comes to this particular rhythm. We may even want to adjust medications. We're going to review and adjust medications based on what's contributing to the arrhythmia. In more severe symptomatic bradycardia cases, you're going to see pacemakers that may be needed in order to help maintain that adequate heart rate. And then lastly, you may even see electrophysiology studies taking place. It's really to evaluate the heart's electrical system for a more targeted treatment in those more complex cases. Next up, we have accelerated junctional rhythms, and they follow the same rules as junctional rhythms. However, they have a little bit of a faster heart rate. Anytime our heart rate is greater than the intrinsic rate, but less than 100, we call these rhythms accelerated. As we know, the intrinsic rate for the atrial ventricular node is between 40 to 60 beats per minute. So anytime the rhythm is between 61 to 100 beats per minute and also meets that junctional criteria that we talked about before, we call that rhythm accelerated. So what's going on here? The rhythm is going to be regular. Our heart rate is going to be a little bit faster, 61 to 100 beats per minute. The P wave is going to remain the same. It has to meet that Ayres criteria. The PR interval is going to be variable depending on if it's there or not. It's going to be less than 0.12 seconds if it is. The QRS complex is going to be narrow and normal, and we're not going to see any abnormal beats. Ultimately, the causes, signs and symptoms, and treatments are going to remain the same. And next up, we are going to have junctional tachycardia. Remember, they're going to follow the same criteria. However, the heart rate is going to increase between 101 beats per minute all the way up to 150 beats per minute. Remember, anytime we have a heart rate that's greater than 150 beats per minute with this narrow or normal complex of our QRS, we're going to be looking at a supraventricular tachycardia. So again, let's look at our breakdown here. The rhythm is going to remain regular. Our heart rate's going to be a little bit faster between 101 and 150 beats per minute. It should still meet that Ayers criteria. The PR interval will be variable depending on if it's there, and if it is, it should be less than 0.12 seconds. Our QRS complex is going to remain narrow and normal, and we shouldn't have any abnormal beats. And as always, the causes, the signs and symptoms, as well as the treatment are all going to remain the same except for one thing. You may see a cardioversion or an ablation that's going to take place here. If the heart rate has become a little bit too high for our liking, we may end up doing a cardioversion or ablation, ultimately to slow down that heart rate. So let's do some practice. Here is our first practice example. So as always, do we have a regular or an irregular heart rate? If I was to measure from each R to R complex, they look exactly the same. So I would say that we have a regular heart rhythm. Next up, we're going to look at our heart rate. So again, for dexterity purposes, we're just going to count the QRS complexes, but just know you should count all of the small boxes in between each R to R complex and divide them by 1500. Here we have 1, 2, 3, 4, 5 QRS complexes, so we have approximately 50 beats per minute. Next up, do we have any P waves? Well, as you can see here, we have this flat line before each QRS complex, and we don't have any extra lines that would make it seem like we have some P wave someplace else. So in this case, I'm going to say that our P wave is absent. Because we don't have any P waves, we don't have a PR interval, so we know that that is automatically eliminated. And if we take a look at our QRS complexes, they do appear to be narrow and normal. So I would say, just based on looking at it, it's probably about 0.08 seconds. And do we have any abnormal beats? Absolutely not, so we can automatically eliminate that as well. So based on the criteria of everything that we see here, especially the fact that we have a slower heart rate and an absent P wave, we know that this rhythm is a junctional rhythm. Let's take a look at our next practice example. So again, we start with rhythm. Do we have a regular rhythm or do we have an irregular rhythm? Based on what I can see here, it looks like everything is falling in the exact same place whenever we measure, so we would call this rhythm regular. Next up, we want to go ahead and count our QRS complexes. I have 1, 2, 3, 4, 5, 6, 7, 8, 9. So I have approximately 90 beats per minute. Then I want to take a look at my P waves. Do I have any P waves? Well, let me see here. Right here, it looks like I actually have maybe a little bit of an inversion here that's taking place. Then I have no P wave. Oh, look at that. I got a little bit of an inversion there too. So the P waves are kind of variable, right? So we have both absent and we're going to have inverted P waves. So because I have inverted P waves, I do have a little bit of a variation when it comes to my PR interval, but ultimately it's going to be less than 0.12 seconds. Next up, taking a look at our QRS complex, it does appear to be narrow normal all the way down our 6-second strip. Again, I'm going to say this is approximately 0.08 seconds based on what I'm seeing. And then lastly, do I have any abnormal beats? Absolutely not. We don't have any of that. So taking a look at our criteria, knowing we have a regular rhythm, it's 90 beats per minute, but I do have this variation in my P waves. I know I'm looking at a junctional rhythm, but I'm not looking at a normal junctional rhythm. I'm looking at something else specifically because of this heart rate. This heart rate is greater than the intrinsic rate, but it's less than 100. So based on what I can see here, I have an accelerated junctional rhythm. Again, the biggest key I want you to take away from this video is that if the rate is greater than the intrinsic rate but less than 100, we call it an accelerated rhythm. And now we're going to take a closer look at our last example. So again, we start with rhythm. Do I have a regular or irregular rhythm? Well, if I was to march out between each R to R wave, I can see here that I have a regular rhythm. So I'm going to go ahead and put that in here. Next up, we want to determine our heart rate. So I have 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. So I have approximately 120 beats per minute. Next up, I want to take a look at my P waves. So as you can see here, I really don't have any P waves that I'm able to note here. So I'm going to say that our P waves are absent. Because I don't have any P waves, there's no PR interval that's going to be measured, so I can automatically eliminate that. And then looking at our QRS complexes, they do appear to all be narrow and normal, which means they're happening at or above the junctions. These actually appear to be a little bit more narrow than the examples we saw before, so I'm going to say that this one is about 0.04 seconds. And then lastly, do we have any abnormal beats? Not that I can see here, so we can eliminate that. So now we're going to take a look at our criteria. I have a regular rhythm. It's 120 beats per minute, so I know I'm dealing with some kind of tachycardia, but the thing that makes this a junctional rhythm is the fact that I have absent P waves. There's no P waves to be seen here, and I have a regular rhythm. So taking a look at this example, I know that I have a junctional tachycardia. So as always, we're going to start with our ventricular rules. So the big thing with ventricular rhythms is they're going to originate, like the name says, in the ventricles. That means that the SA node and the AV node are no longer working, and those Purkinje fibers are having to really start to kick in order to maintain that heart rate. The big thing here, the big thing we've been talking about in all of our videos is that when we see a big, wide, and ugly QRS, this is where it is coming from. It's somewhere within our ventricles or our bundle branches. So anytime you see a big, wide, ugly QRS complex, know that it is always going to have bundle branch or ventricular in the name. That is the biggest key I can help you whenever you're taking those ECG exams, is that if the big, wide, ugly QRS is taking place, it's always going to have bundle branch or ventricular in the name. And as always, that intrinsic rate is also going to be a little bit different, right? With SA node types of rhythms, we're going to see 60 to 100 beats per minute. With AV node types of rhythms, we're going to see 40 to 60 beats per minute. Well, with ventricular types of rhythms, we're going to see an intrinsic rate between 20 and 40 because they're originating from the Purkinje fibers. So these are going to be much slower rhythms. They're not going to be good for the heart, but just know it's the heart's last failsafe in order to maintain life by having this 20 to 40 beat per minute intrinsic rate. So we're going to start with idioventricular rhythms, and they are characterized by their slow, regular rhythm that originates from our ventricles. We typically call these the dying heart rhythms because they're predominantly seen in patients who are on palliative care for end-of-life kind of services. This kind of rhythm is ultimately going to be lethal if it is not intervened because of its slow heart rate. So let's talk about how we're going to break this rhythm down, starting with our rhythm. This rhythm is always going to be regular. If I was to march out between our R to R waves, it's going to fall in the exact same place every single time. The only difference is it's just going to be a very slow rhythm. Like we talked about, that heart rate is going to be very slow because of the intrinsic rate of our Purkinje fibers. So if we were to look here, we have 1, 2, 3, 4, we have approximately 40 beats per minute with this particular idioventricular rhythm. The P waves in this rhythm are going to be absent, right? We talked about that before. That SA node and those AV nodes are no longer functioning. So all of that electricity that's taking place in the heart is only happening down here in the ventricles. So you're not going to see any kind of atrial activity taking place. Likewise, you're also not going to see a PR interval. It's going to be unmeasurable because of that lack of atrial activity. This is the first QRS complex where it is going to differ because we're going to see this big, wide, and ugly QRS complex, meaning that it's going to exceed that normal range of 0.12 seconds. This is ultimately due to the impulse originating inside of our ventricles using that abnormal pathway for ventricular activation instead of the normal conduction systems like we saw in our previous rhythms. So let's talk about the causes. Idioventricular rhythms can occur due to several serious conditions, one of them being a myocardial infarction, also known as a heart attack, especially when the damage impacts the heart's normal conduction system pathways. Next up, we have cardiomyopathies, which are diseases of the heart muscle that impair its electrical conductivity. As always, if we see drug toxicity that's taking place, there are certain medications that can depress the normal function of our SA and our AV nodes. We also have electrolyte imbalances. So if the electrolyte imbalance is severe enough, especially when it comes to our potassium, our calcium, and our magnesium, it's ultimately going to affect the conduction of our heart. And then lastly, reperfusion therapy. This is huge. Occasionally, it is seen after a reopening of a previously blocked blocked blood vessel due to a post-myocardial infarction or other causes. So when we talk about signs and symptoms, we're really talking about the fact that we have this significantly reduced heart rate, and that's what's causing a lot of these symptoms. So we could see a lot of fatigue and weakness that's taking place due to the poor blood circulation, lightheaded and dizziness from low cardiac output. We could even see syncope that takes place, particularly in severe cases where the heart rate is extremely low. And then lastly, palpitations. It wouldn't be something you would really think of, but we do have this awareness that we have this slow, irregular heart rate that's taking place. So that's what's causing kind of those palpitations. And then lastly, shortness of breath, right? So shortness of breath, anytime the heart is struggling to maintain an adequate oxygen supply to the body, it's ultimately going to lead to some kind of shortness of breath of taking place. So lastly, let's talk about our treatment options. So we're talking about treatment, we're solely focusing on addressing those underlying causes and supporting an adequate heart rate and rhythm. So you are always going to see, unless you have a patient that is in palliative care, a pacemaker that's going to be implanted. It is necessary because it's going to ensure that stable heart rate is going to be achieved, and it's going to prevent the symptoms associated with those bradycardias. If it is a medication issue, like we saw with drug toxicity, we could have some kind of medication management that's going to take place in adjusting those particular medications in order to prevent this from happening in the future. And then of course, if it's a electrolyte imbalance, we're going to start to correct those electrolyte imbalances in order to bring the heart back to its normal rhythm. And then lastly, we have accelerated idioventricular rhythm. Again, it follows those same rules as our ventricular rhythm. However, the heart rate's just going to be a little bit faster. This is, again, anytime we have a heart rate greater than the intrinsic rate but less than 100, we're going to call these rhythms accelerated. So this is really key and important for you to know. The intrinsic rate for the Purkinje fibers are going to be between 20 and 40 beats per minute. So if we have a heart rate that is an idioventricular rhythm that is between 41 and 100 beats per minute, this is going to meet that ventricular criteria, and we're going to call it accelerated. So the most common time that you might see this particular rhythm, this accelerated idioventricular rhythm, is going to be with reperfusion therapy, specifically thrombolytic therapy after a myocardial infarction. This is usually seen as a positive sign of reperfusion, but might also compete with the normal sinus rhythm for control of the heart rate. So you might see this rhythm initially, and then ultimately it may go back into that normal sinus rhythm. But you also really need to be very aware after reperfusion therapy that this rhythm doesn't come back, because it is something that can occur with those types of therapies. So again, breaking down the rhythm, we're going to have a regular rhythm. When we march it out R to R, we're going to see that it's going to fall in the exact same place. Our heart rate's going to be between 41 and 100 beats per minute, hence the name accelerated. It's greater than the intrinsic rate, less than 100. We're not going to have any P waves because, again, we don't have any atrial activity that's taking place. The SA node and the AV node are on vacation, and the ventricles are taking over. So no P waves and no measurable PRI intervals. And then again, QRS complexes are going to be big, wide, and ugly. If you take a look at this, look how huge this QRS complex is. So yes, big, wide, and ugly QRS complex is going to be greater than 0.12 seconds. And then lastly, we're not going to see any abnormal beats. As for the causes, the signs and symptoms, and the treatment, they're all going to follow the exact same rules as we saw when it came to our regular idioventricular rhythms. So let's do some practice. What is it that we have here? So based on what I can see, if I was to look at our rhythm starting with that, it looks pretty regular. It's kind of following the exact same place every single time that I march it out. So we're going to call this rhythm regular. If I was to count our heart rate, I have approximately 1, 2, 3, 4-ish QRS complexes, making it approximately 40 beats per minute. I don't see any atrial activity taking place here, right? Because we have these flat lines before each QRS complex. So we can say that our P wave is absent, which means that we're not going to have a PRI interval. And then lastly, our QRS complex. If I was to measure this out, it's huge, right? It starts here, comes all the way down here, and then comes up here. So we have a big, wide, ugly QRS complex. This one's approximately 0.22 seconds. And then lastly, do I have any abnormal beats? Absolutely not. So let's take a look at what we have here. We have a regular rhythm 40 beats per minute. We have a P wave that is absent, and we have this huge QRS complex. So the fact that I have that huge QRS complex means that I'm either going to have bundle branch or ventricular in the name. Based on the heart rate, the big QRS complex, and the regular rhythm, I know that this rhythm is an idioventricular rhythm. And then lastly, we have our last example. So we're going to do the exact same thing that we did before. We're going to measure our R to R process here. If I was to measure it out, it looks like I have a regular rhythm. It's going to fall in the exact same place every time. So we're going to call this rhythm regular. Now I'm going to count our QRS complexes. I have 1, 2, 3, 4, 5, 6, 7, 8, 9 up. I get approximately 90 beats per minute with this one. Next up, do I have any P waves? Not that I can see. Everything before our QRS complexes are pretty flat, right? So we're going to say that we have absent P waves, which means we're not going to have a PR interval. And then our QRS complex, is it narrow, normal, or big, wide, and ugly? If we were to measure it out, it kind of starts here, comes up, comes down to about right here. There's like a little notch right there. It's actually pretty big. So we can absolutely call this one a big, wide, ugly QRS complex. It's approximately 0.20 seconds, so much bigger than normal. And do we have any abnormal beats? Not that I can see, so we can automatically eliminate that. So based on what I have a regular rhythm with a big, wide, ugly QRS complex, but it's approximately 90 beats per minute. So remember, anytime it's greater than the intrinsic rate, but less than 100, we're going to call this rhythm an accelerated idioventricular rhythm. So as always, we start with our lethal rhythm concepts. And one of the biggest things that I want you to know when it comes to lethal rhythms is you need to have immediate interventions taking place, because honestly, your patient at this point is dead. So let's go through the 3 different kinds of lethal rhythms that you're going to need to be aware of, especially when you're taking those ECG exams. Ventricular tachycardia, also known as VTach or VT, is a type of rapid heart rhythm that starts within the ventricles. What's interesting about ventricular tachycardia is that it can occur in the absence of any heart disease and in the presence of structurally normal hearts. This rhythm is typically referred to as idiopathic ventricular tachycardia. Ventricular tachycardia is considered primarily lethal because it disrupts the normal rhythm and pumping efficiency of the heart, which can drastically reduce blood flow to the heart and other vital organs. If sustained or left untreated, ventricular tachycardia can deteriorate into ventricular fibrillation, a more chaotic and ineffective heart rhythm that can lead to sudden cardiac death. The biggest thing I want to note here is that not every patient that has ventricular tachycardia is in a lethal rhythm. There are some patients that kind of just live within this rhythm. So you may be taking care of a patient and they're sitting in their bed playing on their phone, and they could go in and out of this rhythm. Unfortunately, sometimes that's normal. So let's talk about rhythm identification. What's an easy way to identify ventricular tachycardia? Well, you can think of it in one of 2 ways. You can think of it as either being like a tombstone formation, or you can think of it as the other way, as them looking like a V. So that's the big key takeaway if you're trying to identify a rhythm as ventricular tachycardia, is if you see this tombstone-like rhythm or this V-like rhythm, you're most likely dealing with this particular rhythm. The good thing about this is that the rhythm is usually regular. So as you march it out, you're going to be able to see that they're going to fall in the same place, your R to R, every single time you march it out. Your heart rate is usually going to be greater than 100 beats per minute. There's going to be no P waves here, right? Because this is all happening within the ventricles. Atria are no longer working. That's the biggest key takeaway I want you to take away here, is that there's no P wave, no atrial activity. So of course, if you don't have P waves, you're not going to have any kind of PR intervals. Your QRS complex, remember, anytime we have ventricular or bundle branch in the name, our QRS complex is going to be big, wide, and ugly. And as you can see here, our QRS complex is definitely big, wide, and ugly. So it's going to be greater than 0.12 seconds. And then lastly, any abnormal beats. Well, this isn't really normal. We don't have any of those extra beats, those ectopic beats that you would see in those abnormal beats. When it comes to common causes surrounding ventricular tachycardia, remember, sometimes it can be idiopathic, meaning that we really don't know the reason why this happened. It just suddenly occurred. But there are some reasons this could happen. You could see ischemic heart disease. There could be an electrolyte imbalance, specifically like hypokalemia, hypocalcemia, hypomagnesium. So just if you see those lower types of electrolytes, you're probably dealing with some kind of irregularity with your heart rhythm. We also got post-cardiac surgery. You could have dilated and hypertrophic cardiomyopathy. There could even be conduction system diseases that's happening within the electricity of our heart. And these are just a few to name. There's obviously many more causes that could cause this kind of rhythm. So signs and symptoms are like any other rhythm that we typically see whenever we're seeing any kind of irregularity with the heart rhythm. You could have palpitations, dizziness and lightheadedness. Syncope is huge. Fainting can obviously occur whenever there's an irregularity within the heart system. Shortness of breath, chest pain, and the biggest one here that I want you to remember is cardiac arrest. Because as we talked about before, ventricular tachycardia can lead into ventricular fibrillation, which is just cardiac arrest. So when we're talking about treatment for these particular kinds of rhythms, it's really dependent on what's going on with the patient. Do they have a pulse or do they not have a pulse? If they have a pulse and they're stable, then we're going to follow the ACLS algorithm when it comes to tachycardia with a pulse. However, sometimes these individuals can lose a pulse. So in those pulseless situations, we want to follow the ACLS algorithm when it comes to ventricular fibrillation and pulseless ventricular tachycardia. So if you're interested in what this algorithm looks like, specifically if we still have a pulse, this is the general breakdown that was pulled from the American Heart Association's ACLS guidelines for 2022. There will be new guidelines coming out in 2025, but these are the most current guidelines. I'm not going to go heavily into detail about this. If you're interested in figuring out what you're going to do for these patients, if you see this kind of rhythm, I highly recommend that you go check out my ACLS videos where I break it down thoroughly. So next up we have ventricular fibrillation, and this is characterized by a rapid, erratic electrical activity within our ventricles. This is a more severe form of a cardiac arrhythmia. This rhythm is distinguished by this chaotic, disorganized, with no discernible waves or complexes on the ECG. As you can see here, if we were trying to measure this out, it's really going to be really hard to measure this out because nothing falls in the same place and it just looks like artifact on the screen, but it's not. It's an actual rhythm for this particular individual. What's happening here is that the ventricles are quivering rather than actually contracting coherently like we saw before with our more regular rhythms. So ultimately, this quivering is going to lead to a sensation of that effective blood pumping. Just like with ventricular tachycardia, this rhythm can also occur without any prior warning, especially in individuals with undiagnosed heart disease. What's key to note here is that ventricular fibrillation is one of the few cardiac emergencies where immediate intervention with an automated external defibrillator, also known as an AED, can revert the rhythm back to normal, potentially saving this person's life. So let's talk about rhythm identification. So again, when it comes to the rhythm, we have this irregular, chaotic type of rhythm that's taking place. It's very hard for us to measure this out. The heart rate's going to be indeterminate really because there are no peaks or QRS complexes or atrial rhythms that we're going to be able to see in order to identify what this person's heart rate's going to be. And of course, because the atria have kind of given out, again, just like we see with most of our ventricular rhythms, we are going to have absent P waves and no measurable PR interval. What's big here is that when it comes to the QRS complex, it's going to be unidentifiable, right? We really don't know where the QRS complexes are because of this chaotic rhythm. And then lastly, there's going to be no abnormal beats. There's not going to be any ectopic beats or extra beats with this particular kind of rhythm. We just know that ultimately it's going to be lethal. So what are some of the causes behind this particular kind of rhythm? We could see CAD, we could have a myocardial infarction, there could be even scarring taking place on the heart muscle itself from previous infarcts that might have happened. Electrolyte imbalances, like we talked about before, huge whenever we're looking at lethal rhythms. And then of course, ventricular tachycardia that ultimately progressed to ventricular fibrillation could be an additional cause. What's interesting here is that the signs and symptoms are going to be much more severe because this is a much more lethal rhythm, right? You're going to see potentially sudden collapse. This rapid, erratic pulsation of the ventricles are leading to ineffective heartbeats, meaning we're not really getting any contraction out to the body in order to send all of that blood to our tissues. So somebody could potentially collapse, they could lose consciousness ultimately. We're really not going to see a pulse when it comes to ventricular fibrillation. And then of course, cessation of breathing. They're not going to be breathing at that point because nothing's getting any oxygen in order to help them breathe. And of course, sudden cardiac arrest is a big sign and symptom when it comes to ventricular ventricular fibrillation. So when it comes to treatments with these particular kind of rhythms, we want to follow the ACLS ventricular fibrillation and pulses VTAC algorithm. It's going to be a lot of CPR, we're going to be defibrillating, we're going to be giving epinephrine, amiodarone, or even lidocaine. Next up, we have asystole, and this is characterized as a state of no cardiac electrical activity. There's no movement of blood and there's no detectable pulse. As you can see here, another common name for this would be a flat line because there is no activity taking place at all. What's interesting about this rhythm is it's one of the few cardiac rhythms where resuscitation efforts such as defibrillation is not going to be effective because we don't have any heart rhythm to defibrillate. Defibrillation ultimately relies on the presence of some electrical activity in order to reset it. And in asystole, we're not seeing any activity at all. Asystole is lethal because it represents the cessation of all cardiac electrical activity and effective heartbeats. Without a heartbeat, there's no blood circulation, meaning that there's no oxygen or nutrients that are being delivered to our vital organs, including our brain and the heart itself. If left untreated, this condition leads to organ failure and it's fatal without immediate intervention. So what are we looking at when it comes to rhythm identification? Well, the rhythm's going to be absent, our heart rate's going to be absent, we have no P wave activity at all in order to see a P wave or PR interval, and the QRS is also going to be absent. We are literally just dealing with a flat line. This happens to be one of the most easiest rhythms to identify because of the absence of electrical activity. So whenever we're talking about causes, we're looking at the 5 H's and T's. So we start with our H's. We have hypovolemia, we have hypoxia, hydrogen ions, hypo or hyperkalemia, and hypothermia. So starting with hypovolemia, that means that we have a low blood volume that can lead to an inadequate cardiac output and cardiac arrest. With hypoxia, we're having an insufficient oxygenation of the blood that will ultimately lead to cardiac failure. Hydrogen ions, also known as acidosis, is an acid-base imbalance that can disrupt cellular processes and cardiac function. Hyper or hypokalemia means that we're seeing an abnormal potassium level that can lead and ultimately affect cardiac electrical activity and muscle function. And then lastly, with hypothermia, we have someone who has an extremely low body temperature that can slow down metabolic process and electrical conduction pathways in the heart. Moving on to our 5 T's, we have tension pneumothorax, cardiac tamponade, toxins, or we could have thrombosis in either the lungs or the heart. With tension pneumothorax, we're dealing with an accumulation of air in the chest cavity that puts pressure on the heart and is ultimately going to impair the ability for the heart to pump effectively. With cardiac tamponade, we're going to see an accumulation of fluid in that pericardial sac. If we have more fluid in that sac, it means it's going to be compressing down on the heart and it's going to hinder the heart's abilities to actually expand and contract appropriately. When it comes to toxins, there could be various substances in this situation. You could be dealing with things like medications, beta blockers, calcium channel blockers, or even overdoses of other kinds of medications or illicit drugs can ultimately lead to this life-threatening toxicity. Thrombosis, when it comes to the pulmonary, means that we have a blood clot in the lungs that's ultimately going to obstruct the blood flow and lead to cardiac arrest. And the same thing when it comes to coronary thrombosis. We're going to have a clot somewhere within the coronary arteries that can stop blood flow to a part of the muscle. If that muscle is not getting blood, then we're ultimately going to see a sensation of that heart from being able to pump appropriately because it's not getting the oxygen and the nutrients it needs in order to pump effectively. So what are you going to see when it comes to signs and symptoms of the most lethal rhythm, right? Well, of course, we're going to see an absence of a pulse. The person's going to be unresponsive. They're going to lose consciousness. No breathing is going to be taking place because nothing's getting oxygenated. And then, of course, you're going to see pallor and cyanosis. Basically means that the person's going to be either very, very pale or they're going to turn blue. And when it comes to treatment of this particular kind of rhythm, we're going to follow the ACLS algorithm for PEA and asystole. The biggest difference here is we're not going to be defibrillating because there's nothing to defibrillate in these particular cases. So we want to make sure that we're following this particular algorithm for these more lethal rhythms. So I know we talked about there being 3 primary lethal rhythms, but there's actually a 4th. It's just not commonly talked about. In this case, it's called pulseless electrical activity, and it's characterized by an organized electrical activity of the electrocardiogram without any corresponding mechanical heart contractions Hence, we don't have a detectable pulse. With PEA, there's not a single specific rhythm. Rather, it can be any rhythm. It could be normal sinus rhythm. It could be literally anything. The only difference is there's no pulsation taking place. So the big key here that I want you to remember is that when it comes to PEA, you're going to see electrical activity on the screen. But the electrical activity does not mean that the mechanical activity is taking place. Even though the heart's electrical system might be functioning appropriately, it may not be receiving the signals it needs in order to help the heart contract. So while we say electricity, just remember that electricity does not mean mechanical activity. So when it comes to rhythm identification, again, any of this can be variable because we really don't know what the rhythm's going to be. The biggest key here is when it comes to signs and symptoms is you're not going to have a pulse. There's going to be no pulse present with these rhythms. So when we're looking at treatment, we're going to follow that same algorithm that we saw for asystole, right? We're going to be doing some CPR, giving some epinephrine, and we're going to try to treat those H's and T's if they're applicable. So again, here is the ACLS algorithm when it comes to adult cardiac arrest, more specifically ventricular tachycardia, pulseless ventricular tachycardia, asystole, and PEA. We're not going to be going heavily into this because I do have an entire ACLS video that talks about this in depth, but just know, depending on what's going on, you're going to follow one side if you have ventricular fibrillation or pulseless VTach, or you're going to follow the other side when it comes to asystole and PEA. So let's do some rhythm identification practice. So we have our first rhythm here. Is our rhythm regular or irregular? Well, if I was to actually march this out, you're going to see it falls in the exact same place every single time. So we're going to call this rhythm regular. Next up, we're going to count our heart rate. So I've got 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14. I got approximately 140 beats per minute. Do I see any atrial activity? No, I don't see any here, right? So we know we're not going to have any P waves, and we know we're not going to have a PR interval. So those are both going to be absent. Now, is my QRS complex big, wide, and ugly, or is it narrow and normal? Well, if I look at this, it's huge, right? Look how big this QRS complex is. It's quite large. So if I was to count out all my small boxes, I would say I'm going to have about 0.22 seconds when it comes to my QRS complex. And do I see any abnormal beats? No, I don't see any abnormal beats here. So the big thing here is I have no atrial activity, I have a big, wide, ugly QRS complex, and I have what looks like tombstones, right? These kind of look like tombstones, or you can say they look like V's. So as I know, whenever I have a rhythm that looks like this, I am dealing with a ventricular tachycardia. So taking a look at our next rhythm, what do we have here? It looks really chaotic, right? So when it comes to rhythm, it's going to be irregular, because if I was to try to march this out, I'm really not going to be able to march this out appropriately just because how rapid and chaotic this kind of rhythm is. When it comes to my heart rate, I don't really have any kind of organization that's taking place here. So really, I'm not 100% sure what the heart rate is. With P waves, I don't see P waves here. It's just too erratic. So the P waves are going to be absent, and our PR interval is also going to be absent as well. If I try to measure QRS complexes, again, it's going to be really hard because I don't have any kind of regularities here that I can actually look at. So this again is going to be unidentifiable. And do I see any abnormal beats? Again, I don't. It's just really, really chaotic. So the big thing here is I have an irregular rhythm that's very chaotic, and I'm not really able to identify anything here. We know that this is a very lethal rhythm, right? Because we can tell by the fact that there's just no organization taking place. So the only rhythm that looks like this, that is lethal, that follows all of these guidelines here, is going to be our ventricular fibrillation. And last up, I think we have the easiest identifiable kind of rhythm, but we're going to go through it. Do we have a rhythm here? No, right? There's no rhythm at all taking place here. I'm able to find a heart rate because I just have this flat line appearance. There's no P wave activity. There's no PR interval. QRS complex just doesn't exist, right? It's just this completely flat line here. And then of course we have abnormal beats. So what am I dealing with if I've got this flat line? You guessed it, we're dealing with asystole. So we're going to begin with heart block rhythm concepts. What specifically do we need to know about these? Well, the big thing is that heart blocks are blocks in the conduction system. They either can be a delayed block, a progressive delay, a prolonged wave, or they can even have a drop wave. So the big thing here is that blocks can take place in one of two places. They can take place up here in the atrioventricular area, meaning that it's an AV block, or they can take place a little bit lower down in the bundle branch area, making them BB blocks. So what's an easy way to remember all of these different kind of heart blocks? Well, we have the mnemonic TGIF. So let's break each one of these down. The big key when it comes to heart blocks is we're looking at issues with the PR interval. So with the first degree heart block, our T stands for too long, meaning that the PRI is going to be too long. It's going to be outside of our normal values. With our second degree type 1, the PRI is getting, that's our G, longer, longer, longer until eventually we have a dropped QRS beat. The second degree type 2 means that the PRI is going to be identical, that's our I, when it is present. So anytime we have a P wave that has a QRS complex behind it, that PRI is going to be identical every single time. And then lastly, we have our third degree heart block. The PRI is hard to figure out, that's our F, right? The atria and the ventricle are not communicating with each other, so it's going to be really hard for us to identify a true PRI interval that's consistent throughout the entire strip. So starting with our first degree heart block, this is characterized by that prolonged PR interval on our ECG. In this condition, every electrical impulse from the atria is conducted to the ventricles, but that conduction takes a little bit longer, right? There's a slower conduction leading to that elongated PR interval. So if we were taking a look at this ECG strip, you're going to see we have a P wave here, but look how long that delay is in between our atrial depolarization and our ventricular depolarization. Otherwise, everything's normal here. You're not going to see any drop beats. There's going to be no irregularities in this rhythm. It just happens to be that we have this elongated PR interval. With this kind of rhythm, it's the more mildest form of our heart blocks. Many individuals don't even know that they have it. They can be asymptomatic, and usually it's not going to require any kind of treatment. What's interesting to note is that this can be seen in even healthy individuals, including well-trained athletes, where this might actually be a normal physiological adaptation. So taking a look at rhythm identification, the rhythm is going to usually be regular, right? You're going to be able to march everything out. Everything's going to fall in the correct places. The heart rate usually is going to fall between 60 to 100 beats per minute, and the P wave is going to be normal. It's going to be upright. It's going to be before each QRS complex. The big key here, like we talked about before, is that PR interval is going to be greater than 0.2 seconds. It's going to be outside of our normal range. However, the good thing is that the QRS complex is going to be narrow and normal, right? This is a nice tight QRS complex. So we know that it is, a good rhythm. We're not seeing any of these big, ugly, wide QRS complexes. We just happen to have a little bit of an issue with the delay in the conduction. And then like we talked about before, there's going to be no abnormal beats. Just like with bundle branch blocks, this is another rhythm where you're going to have to identify the underlying rhythm. So in this case, because everything appears to be normal, we could say that this is a normal sinus rhythm with a first degree block. So what are some of the causes that you might see? Well, there could be an intrinsic AV node disease. Like we talked about, the AV node is that node that prevents that information from getting down to the ventricles. It gives it a little bit of time for that atria to really contract and get all of that blood into those ventricles as possible before the ventricles ultimately do their contraction. We could see an enhanced vagal tone, maybe even acute MI could be taking place. Electrolyte imbalances are huge. Anytime you see any kind of irregularity when it comes to ECGs, check your electrolytes, see what's going on. You could have myocarditis, you could have CAD, or you could even see some antiarrhythmic medications that could lead to this delayed process. When it comes to signs and symptoms, typically these individuals are going to be asymptomatic. They're usually discovered accidentally on an ECG, and it could be an indicator of some kind of underlying heart disease that's taking place or electrolyte imbalances, but generally it doesn't really have a whole lot of symptoms attached to it. And because of that, treatment's not necessarily required in these individuals unless they become symptomatic. Next up, we have second-degree heart block type 1. This is the first type of heart block that you are not going to have to identify the underlying rhythm. So what is a second-degree heart block type 1? Well, it's also known as a Winkie-Bach or a Mobitz type 1, and it's characterized by a progressive lengthening of our PR intervals followed by a dropped beat. So if you look here, we have a short PR interval, then it gets a little bit longer, and then it gets a little bit longer. And then right here we have a P wave with nothing behind it, right? We get ghosted, right? Our QRS just gave up. So that's what's happening with our second degree heart blocks, is just going to get longer, longer, longer drop. And that is our second degree type 1. So with ECG rhythm identification, the atria is typically going to be regular and the ventricular rhythm is going to be irregular because of that dropped beat. The heart rate, really depends. It can be normal, it can be slow, depending on what's going on with this particular delay. The P wave is going to be present, it's going to be upright, it's going to definitely be there. And of course, our PR interval is going to get longer, longer, longer before we ultimately see a drop. And then with our QRS complex, narrow and normal typically is what it's going to be. As you can see here, it's nice and tight. It's a nice narrow normal rhythm until ultimately you have this drop take place and it's not even there at all. And then lastly, abnormal beats. Well, I just put in that we have a dropped QRS at this point. That's a little abnormal, right? Because we would typically see a QRS right behind this drop beat and right behind this drop beat. So yes, that dropped QRS is going to be abnormal on this rhythm. So what are some of the causes behind this? There's certain medications like digoxin, calcium channel blockers, even beta blockers and antiarrhythmics that can lead into this more progressive block. There could be an inflammatory or metabolic vascular disorder that's taking place. You could see an acute MI, even post-cardiac procedures, as well as surgeries. More specifically, cardiac ablations. This tends to be one of the common rhythms if somebody was to go into an abnormal rhythm with having those kinds of procedures. And then we have valvular disease, OSA, which is obstructive sleep apnea, or even alcohol poisoning can lead to this. When it comes to our signs and symptoms, typically they're going to be asymptomatic. If they do start to experience symptoms, it's most likely going to be palpitations or lightheadedness, and that's again very rare in these kinds of rhythms. And when it comes to treatment, we really don't treat this rhythm unless they become symptomatic. If they do become symptomatic, then we are going to follow our ACLS algorithms. We might be giving them atropine in this particular situation if the heart rate's too slow. And if the heart rate's too slow and it's not responding to atropine, we may even be looking at transcutaneous pacing until a transvenous pacer is placed. Next up, we have a second degree heart block type 2, and this is known as a Mobitz 2. And it's characterized by a sudden and unexpected failure of some atrial electrical impulses to conduct down into our ventricles without prior lengthening or PR intervals like we see with type 1. So in this case, remember the I stands for identical. So our PR interval is going to be identical when it is present. So if I was to measure this PR interval with this PR interval with this PR interval with this one, you're going to find that they are going to be identical. But what we have here is we have a P wave and nothing behind it. P wave, nothing behind it. P wave, nothing behind it, so on and so forth, all the way down. So that's how you can tell that you have a second degree type 2, is that now my PR interval looks exactly the same every single time when I have a QRS complex there. However, I do have some drop beats behind some P waves. So that is the big difference between type 1 and type 2. So what are we going to see here when it comes to rhythm identification? Well, again, the atria should still be regular and our ventricular rhythm is going to be irregular due to those drop beats. The heart rate is going to be dependent on what's going on with the heart rhythm. It could be normal or it could be slow. The P wave is going to be present and upright. As we know, whenever we have them, they look good with these second degree type 2s. The PR interval, like we talked about before, is going to be normal and constant when a QRS complex is there. And what's interesting about the QRS complex is depending on where the block is taking place, we could see one of two things. We could see narrow and normal QRS complexes, or we can see big, wide, and ugly QRS complexes. In this case, we have nice, narrow, and normal complexes, so most likely it's taking place somewhere up there in that atrioventricular node. And then lastly, when it comes to abnormal beats, of course, we're going to see those drop QRS complexes. So the causes here are really going to follow the second degree heart block type 1, but the big difference is that you're going to see post-TAVR. So TAVR is a specific procedure when it comes to replacing a valve inside the heart. In this case, second degree heart block type 2 is very common in these individuals, and it's much, working as a CVICU nurse in the past, you really have to keep a very good eye on these TAVR patients because they tend to go in these kinds of rhythms and they're easy to reverse as long as we can identify it early. When it comes to signs and symptoms, they usually usually are more symptomatic than we see with our previous heart blocks. It can lead to a sudden drop in heart rate. You're going to see potentially even syncope, fatigue, chest pain, palpitations taking place. They really do tend to be more symptomatic. And because they're more symptomatic, that means we're going to be treating these individuals more aggressively. So again, transcutaneous pacing until we get that transvenous pacing available to us. They may even be put on medications like dobutamine, dopamine, or epinephrine, which are beta-adrenergic agonists, if they're unstable, depending on how this particular person presents. Atropine in this situation is going to be really ineffective. There's no point if we have a slower heart rate to give these individuals atropine because it's not going to really do a whole lot. And of course, we want to treat any reversible causes. In this case, if it was a TAVR situation, then they might have to go back in and replace or whatever it looks like for that individual. Now let's talk about our last heart block, which is a third-degree heart block, also known as a complete heart block. And this is characterized by the complete disassociation of our atrial and our ventricular contractions. This occurs because the electrical impulses generated by our atria do not pass into our ventricles. On an electrocardiogram, you're going to observe that the P waves that occur at a regular rate occur independently of our QRS complexes, which also appear to be regular. So both our atria and our ventricle are regular, but they are not talking to each other. So you might be questioning, why is this heart rhythm lethal? Well, a third-degree heart block is lethal because the ventricles rely on their backup pacemaker systems known as their Purkinje fibers, which are primarily slower and less reliable than our normal sinus node. This can ultimately lead into reduced cardiac output, leading to severe symptoms if not adequately treated. And the risk of asystole increases greatly when it comes to this rhythm because it's relying on those escape rhythms in order to make the ventricles contract. So what are we looking at when it comes to rhythm identification? Well, we have the atria and the ventricle. They're going to be regular but independent of themselves. If I was to measure out my atria on my strip, they're going to fall in the exact same place every single time. And our ventricles are going to do the same thing. They're also going to fall in the exact same place every single time, but they're not going to be dependent on each other. When it comes to our heart rate, our atria is going to be between 60 to 100 beats per minute, and our ventricles are going to be between 20 and 40 beats per minute. Remember, we're relying on those Purkinje fibers that usually beat between 20 to 40 beats per minute. Our P waves are going to be upright and normal typically, but you're not going to see a PR interval in this case because we don't have any correspondence between the atria and the ventricles. The QRS complex, again, can be narrow, normal, or it could be big, wide, and ugly. Most of the time it's going to be big, wide, and ugly because it's only receiving information down there from the Purkinje fibers. And then lastly, we're going to see abnormal beats. Not really, right? This entire thing is an abnormal beat. So in this particular case, there's really not going to be any kind of abnormalities when it comes to this rhythm. There are a ton of different causes when it comes to third-degree heart blocks. There could be certain medications like we talked about before with DIG, calcium channel blockers, beta blockers, and antiarrhythmics. Again, we can see that inflammatory or metabolic vascular diseases, not very common, but it can happen with post-cardiac procedures and surgeries. There could be like a hypoxia, acidosis, hyperkalemia situation taking place. So we definitely want to make sure we're checking our H's and our T's. And then lastly, there could be like a valvular disease or some kind of hypothyroidism that has been left untreated that could ultimately lead to this kind of rhythm. So with third-degree heart block signs and symptoms, you're going to see significant symptoms due to that disassociation between our atria and our ventricles. So the symptoms are going to be much more severe. You're going to see very severe fatigue, dizziness, syncope, and sometimes you're even going to hear people say, I feel like I'm dying, because it's just their heart is so erratic because they're not talking to each other. It almost feels like they're dying. You're going to hear people say that. So when it comes to treatment of our third-degree heart blocks, we're going to follow the ACLS algorithm when it comes to bradycardias. So atropine is an option to provide to these individuals to see if that will help turn it around, but I can almost guarantee you that they're going to end up with some kind of transvenous pacemaker. It's very rare that they don't. 9 times out of 10, they usually end up with a transvenous pacemaker, but usually before that, we're placing those transcutaneous pacemakers, which is the pads that sit on top of the chest. So it's going to be very uncomfortable for the individual. Make sure that they have a lot of pain medication on board because we want to make sure that they are calm and that they are not experiencing too much pain. And then of course we can even consider things like dopamine and epinephrine infusions if all else fails. Taking a look at our next practice question, is our rhythm regular or irregular? Well, if I was to march this out, you're going to see that this happens to be a regular rhythm. So we can definitely say this is irregular. What is our heart rate? Let's count our QRS complexes. We have 1, 2, 3, 4, 5, 6, 7, 8, and 9. So we have approximately 90 beats per minute. Do we have P waves? We absolutely do, right? We have a P wave here, 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 so on and so forth. So they are definitely present. Well, what's happening with these P waves? If I was to measure this out, you can see that this PR interval is very long, right? It's much longer than what we saw originally with our previous practice question. So this is approximately 0.28 seconds. Our QRS complex, looking at it, it does appear to be narrow and normal. So I would say it's less than 0.12 seconds. And do I have any abnormal beats? I absolutely do not. So what do I have here? I have what looks to be a regular rhythm, right? I have a regular rhythm, 90 beats per minute. P waves are present. I have a nice, narrow, and normal QRS complex. So I look like I'm looking at a normal sinus rhythm, but the only difference here is I have this very long PR interval. So if I have a regular rhythm with a long PR interval, which heart block do I have? You got it. I have a first-degree heart block. In this case, you want to identify the underlying rhythm. So we would call this a normal sinus rhythm with a first-degree heart block. So what kind of rhythm do we have here? So if I was to measure out my QRS complexes, oh, look at that. I'm missing a QRS complex here. So I know I'm dealing with some kind of block. And if I was measured out, this would be regular. So this case, I have atrial, which is regular, and then my ventricular is irregular. So what is my heart rate? Let's count our QRS complexes that we have here. So I've got 1, 2, 3, 4, 5, 6. So we get approximately 60 beats per minute with this rhythm. Do I have P waves? I absolutely do. I have a P wave here, P wave here, P wave here, P wave here. So they are present in this situation. But when I'm looking at my PR interval, I'm noticing some kind of pattern here. So right here, it's a little short, and then it gets a little longer, then it gets a little longer, and then I have a P wave and nothing behind it, right? We get ghosted. And then it goes back to that same pattern. It's a little short, gets a little bit longer, and then again, I have a drop. So we have a PR interval that is getting longer as we move down our 6-second strip. What about our QRS complex? If I'm looking at my QRS complex, it is definitely narrow and normal. It's nice and tight here. So I would definitely say it's less than 0.12 seconds. And do I have any abnormal beats? I do. I have a drop QRS, right? I'm missing some beats here. So taking a look at this, I have my atria, my ventricle. Atria are regular, ventricles are irregular. My P waves are present, but this is the big thing. That PR interval is the big thing. I'm getting a longer PR interval until eventually I have a drop. What heart block is characterized by that? You are absolutely correct. The correct answer for this is going to be a second-degree heart block, type 1. So what do we have here? We have a heart rhythm. We see, taking a look at our QRS complexes, they're not really regular when it comes to QRS, but if I was to measure out my P to P interval here, I do have atria that are correct. So my atria are regular and my ventricles are irregular. What's my heart rate? Well, in this situation, my heart's going to be a little bit slower that I can see, right? 1, 2, 3, 4, 5. So I have a ventricular heart rate of approximately 50 beats per minute. It's a little slow. Do I have P waves? I absolutely do. They are present. But what's interesting about these P waves, let's take a look at our PR intervals. So here, when I measure this one and compare it to this one, compare to this one, compare to this one, compare to this one, they are all identical, right? So they're identical when they are present. And what about my QRS complexes? These are very different from what we've been seeing before, right? These are huge. These are big, wide, ugly QRS complexes. So these are definitely going to be greater than 0.12 seconds. And do I have any abnormal beats? I absolutely do, right? I have a P wave with nothing behind it here, a P wave and nothing behind it here, P wave, nothing behind it, so on and so forth all the way down. So I definitely have some dropped QRS complexes. So I know I'm dealing with a heart block. What makes heart blocks special is we're looking at the PR interval. So what's happening with our PR interval that we can see here? Well, the PR interval is identical when it is present. Which heart block is identical when it is present? You are absolutely correct. It is a second-degree heart block type 2. Let's take a look at our last practice question. So when we're looking at our rhythm, is it regular or irregular? Well, if I'm looking at my P to P interval, it looks regular here, right? I can march it out. And if I look at my R to R interval, they also look regular. But the problem is there's no organization between them. So while they are all regular, they are regular independently of each other, right? So do I have a heart rate? I do. I can look at both, right? I can count my P waves. So I have 1, 2, 3, 4, 5, 6, 7, 8. I have approximately an atrial heart rate of 80 beats per minute. And then when it comes to my ventricular heart rate, I have 1, 2, 3. I have approximately 30 beats per minute, right? So my ventricular heart rate is very slow, and my atrial heart rate seems to be within normal. Do I have P waves? I do, right? I can identify my P waves as I move down this strip, so they are definitely present. But do I have a PR interval? Not really, right? I can't really identify any consistency when it comes to the PR interval because this one's really, really long. Then if you move a little bit down, this one's behind the QRS complex. This one's even longer, right? We have nothing behind it. This one's hugging. This one, again, nothing behind it. This one's longer than any of these, right? It just doesn't make any sense. Do I have QRS complexes? I do. And in this particular case, they appear to be narrow and normal. So this is going to be less than 0.12 seconds. And do I have any abnormal beats? Not really. The biggest key here when it comes to this particular kind of rhythm is the fact that I have an atrial and a ventricular rhythm that are both working appropriately. They're just not speaking to each other. So anytime we see this chaotic kind of rhythm, we're most likely dealing with a third-degree heart block. So what are some common concepts or rules that we're going to need to know when it comes to pacemaker rhythms? Well, as we know, a pacer spike is going to occur before the waveform that it is pacing. So you can have one of two things occurring. You could have a pacer lead that's sitting up here in the atria, which would be causing a atrial pacing rhythm to occur, meaning we're going to see a pacer spike before our P wave. Or you can have a lead sitting down here in the ventricles, meaning that we're going to see a spike before our QRS complex. And that also tells us that we have ventricular pacing, of course, because it's sitting down here in the ventricle. Or you could have a dual pacemaker, where you've got one lead sitting up here in the atria, and you have another lead down here in the ventricle. That means you're going to see a spike before the P wave and the QRS complex, meaning that we have an atrial ventricular AV pacing. Because the electricity is coming from the pacemaker, and it's not actually coming from the heart's own electrical conduction system, the waveforms that you're going to see in your ECG may appear to be a little bit different. That's very common. The last thing I want to discuss is that pacer spikes do not mean we have mechanical capture. What exactly does that mean? Even though we are seeing electricity on our ECG, it doesn't mean that the heart's actually receiving the electricity. So while we see waveforms like we saw with PEA, it doesn't actually mean that the heart is actually contracting. So you really need to make sure that you're watching these individuals really carefully because they can go into asystole and we wouldn't even know it. So we're going to start with atrial pacing. Atrial pacing is a rhythm that's characterized by a pacing spike that precedes each P wave, indicating that we have an artificial pacemaker that's initiating the heart's atrial activity. In situations requiring atrial pacing, it means that the SA node typically does not function adequately, either due to there being an intrinsic node dysfunction, or there could even be extrinsic factors like medications, as well as underlying heart disease. The pacemaker takes over the role of the SA node by sending electrical impulses at preset intervals to stimulate the atrial contraction. So the pacemaker's lead is going to be placed up here in that right atrial wall. And when the device is triggered, that triggering is going to emit a small electrical charge that's going to depolarize or contract our atrial tissue. It's going to stimulate that natural pacemaking activity that we would see with the SA node. So what are some common indications as to why we would need atrial pacing? So one of the things could be sick sinus syndrome. This occurs when the SA node fails to generate impulses regularly at an appropriate rate. Wires can be placed with sinus bradycardia only in specific situations where the slow heart rate does not meet the body's circulatory demands. Some atrial fibrillation with slow ventricular response may also require this. Usually we try to do it with medical management first to control the ventricular rate, but if all else fails, we can place a pacemaker. And then lastly, we have AV blocks. This is typically common whenever we're seeing any kind of heart blocks from taking place, particularly in cases where only atrial pacing is required and the AV conduction remains intact. Next up, we have ventricular pacing, and this is characterized by a spike that's going to be right before each QRS complex on our 6-second strip. A pacemaker lead is going to be surgically implanted into one of our ventricles. Typically, it's going to be the right ventricle, and when it is activated, again, it's going to emit that electrical impulse to depolarize the ventricular myocardium. This direct stimulation is going to cause the ventricles to contract and pump blood throughout the body without having to actually rely on the natural atrial contraction as well as the AV nodal transmissions. So what's key here is that as a result, the ventricular pacing is going to produce these wider QRS complexes than you would naturally see, reflecting that the unnatural spread is taking place due to the electrical activity coming from the actual pacemaker and not through the conduction systems like we see with the Purkinje fibers. So common indications when it comes to ventricular pacing can include a complete third-degree heart block. This is so common, is if we cannot control that complete heart block, you're almost always going to see a pacemaker that's going to be placed. The big reason why we would see this is particularly because of the fact that the intrinsic rate of our ventricles is between 20 and 40 beats per minute. That's not enough for us to sustain life. So what they do is they place this pacer lead down here in the ventricles at a preset determined rate so that it can continue to contract and beat and push that blood out to the body even though we're having an issue inside the conduction system of our heart. And we can also see a significant bilateral bundle branch block. In this particular case, we have this impairing of that natural electrical flow to our ventricles, just like we saw with our complete heart block. We can also see this with certain heart surgeries. If a heart surgery may affect the natural conduction pathways, we may have to place a pacemaker in order to help it retrieve its normal beat. And then lastly, we have cardiomyopathy and extensive heart disease. In both of these cases, we may see extensive electrical conduction issues, which would give us a reason to place this kind of pacemaker. And then we have atrial ventricular or AV pacing, and this is often referred to as dual chamber pacing because it involves the simultaneous and coordinated pacing of both our atria as well as our ventricles. So in this particular case, we are going to place one lead up here in the atrium and another lead down here in the ventricle. And when you're looking at an ECG, you're going to see that you're going to have a pacer spike before your P wave and another pacer spike before your QRS. The goal of this kind of pacing is to closely mimic the natural timing and sequence of the heart's electrical system, promoting a more efficient cardiac function. So what conditions would want to warrant a AV pacing type of pacemaker? Well, starting, we can see a significant AV block, more specifically a second degree type 2 or third degree block, where that electrical signals from the atria are going to fail to reach our ventricles consistently every single time. We can even see a worsening 6 sinus syndrome, more specifically a 6 sinus syndrome with AV block, where both the sinus node and the AV node are going to be impaired. Heart failure that leads into an AV block is also a common reason for this pacemaker. Typically, patients with heart failure might benefit more from having a synchronized cardiac pacing due to the fact that they already have impaired cardiac output, and it also helps reduce a lot of the symptoms that they see. Other common causes can include fibrosis, ischemic damage, congenital defects, as well as degenerative changes associated with aging. So sometimes a pacemaker can malfunction, and failure to capture and failure to pace are two significant complications associated with cardiac pacing. And it's really important for you to understand the differences because both of them come with their own risks. So starting with failure to capture, this occurs when the pacemaker emits an electrical impulse, but it's not sufficient enough to depolarize our myocardium, resulting in no corresponding contraction. So if we take a look at our strip, you can see here that we have a ventricular pace rhythm. We have a pacer spike before each QRS complex. But as you can see right here, we have a pacer spike with nothing behind it. It's like our QRS ghosted us. Essentially, what's happening here is the heart is not capturing the impulse. You can think of it as Capture means no contraction or complex, or you can even think of it as being there's a problem with the heart. The pacemaker's working, we can see the spike, but the heart's not receiving the electricity. And then next up we have failure to pace. And this happens when the pacemaker itself fails. It fails to emit that electrical impulse at that scheduled time, or intermittently fails throughout all of those scheduled times to deliver those impulses. An easy way to remember this is no shock, no show, meaning that we're not going to see a pacer spike here, right? We can look at our 6-second strip and see a pacer spike here with a QRS, pacer spike here with a QRS, and then just nothing here happened, right? So if we have no shock, we're not going to show anything on our ECG. You can also remember this as the problem lies with the pacemaker, right? It's literally in the name. Failure to pace. It's the pacemaker that's having the problem, not the heart. So it's important to know that with both of these different kinds of malfunctions is that they can be transient or they can be persistent. And there could be various factors that may be influencing them, such as a lead being dislodged someplace in the heart. The battery in the pacemaker itself could be depleted. We could see electronic malfunction as well as programming errors. And then lastly, we have oversensing and undersensing. And these are two critical phenomena that are related to the performance of cardiac pacemakers, representing opposite problems with how the pacemaker detects cardiac and extracardiac signals. So oversensing occurs when the pacemaker mistakenly detects electrical signals as true cardiac events. So as you can see here, we have this artifact or all of this electrical noise that's taking place. It could be due to muscular activity or external interference, but it's thinking that this is true cardiac activity, which means it's not going to send any pacemaker spike throughout this entire time because it doesn't want to overly pace the heart. And then we have the complete opposite of oversensing. We have undersensing. And undersensing happens when the pacemaker fails to detect actual cardiac events. And what I mean by that is it's the person's own intrinsic rate that's happening underneath the pacemaker's preset settings. This is going to result in unnecessary pacing that can lead to pacing during vulnerable periods of time in our cardiac cycle. Or it can have a failure to deliver pacing when it's truly needed. So as we can see from our 6-second strip, we've got a couple areas that are a little bit concerning, right? We have a pacer spike that was right before this QRS, almost in the QRS. And then we have another pacer spike that's in between our QRS and our T wave. These are both really vulnerable situations. So if we don't address this, this can actually lead to lethal rhythms. So a helpful mnemonic in order to remember both of these is overly cautious and under-responsive. Overly cautious refers to oversensing, where the pacer sees too much and may halt pacing unnecessarily. And under-responsive refers to undersensing, where the pacer doesn't even see enough and fails to respond appropriately. PACs, PJCs, and PVCs are all types of premature heartbeats that have an extra beat that interrupt the regular rhythm of the heart. Each of these rhythms originate from different parts of the heart's electrical conduction system. So starting with our premature atrial contractions, also known as PACs, these particular ectopic beats are going to originate in the atria, which are above the ventricles. PACs happen because ectopic foci or irritation in the atria are going to fire an impulse before the SA node is due to fire their own. This can be caused due to a variety of factors like atrial enlargement, stress, caffeine, and alcohol. PACs typically show a normal QRS complex, meaning it's going to be narrow and normal, but we're going to have an abnormally shaped upright P wave that appears sooner than expected. The big key when it comes to PACs is you're going to have a PR interval that's going to remain within normal limits. And next up we have premature junctional complexes, and these are also known as PJCs. They're going to originate in the AV node or the junctional area around it. PJCs again are going to arise from some kind of ectopic foci that's happening in the AV junctional area. They often occur when the natural pacemaker's activity, which is the SA node, is suppressed or the AV node takes over prematurely. possibly due to there being an enhanced automaticity or a triggered activity that's taking place in this area. PJCs typically do not have a preceding P wave, but it also has to meet the Ayres criteria when it comes to P wave presentation, just like we saw with junctional rhythms. So that means that the P wave either has to be absent, inverted, retrograde, or short. The other big key here is that the QRS is going to be narrow and normal because it's happening at or above the junction. And lastly, we have premature ventricular complexes. These are always the easiest to spot because they originate from the ventricles. PVZs result in ectopic foci that are happening in the ventricles, causing them to fire a little bit early. Common reasons that this occurs could be scarring from previous myocardial infarctions, hypoxia, or even imbalances in electrolytes that affect the ventricular myocardium's excitability. Here's a key tip. If you had too many energy drinks like I did when I was in nursing school, you've probably experienced PVCs. PVCs display this big, wide, ugly QRS complex because the impulse spreads across the ventricles irregularly and not through the usual conduction pathways. While PACs, PJCs, and PVCs can occur in healthy individuals without any presence of heart disease, the fact that they are there can indicate underlying cardiac conditions, especially if they become more frequent. PVCs in particular are noteworthy because if we see a frequency of these PVCs taking place, it can sometimes lead to cardiomyopathies, which is a disease of the heart muscle. So we're going to spend the remainder of this video talking about PVCs because they are the most threatening when it comes to our ectopic beats. PVCs can manifest into several forms. We have unifocal, multifocal, and even couplet PVCs, each carrying their own significance and implications when it comes to cardiac function. Starting with unifocal PVCs, they originate from a single ectopic focus inside of our ventricles. This means when you see PVCs on your 6-second strip, they're going to appear to be identical. These are generally considered less concerning than multifocal PVCs. Unifocal PVCs can still be significant if they occur frequently, particularly in patients with underlying heart disease. And then we have multifocal PVCs, and these are going to originate from multiple ectopic foci found inside of our ventricles, leading to PVCs that are going to look a little bit different. As you can see here, we've got a more positively reflected PVCs when it comes to the isoelectric line, and this one's a little bit more negatively deflected from the isoelectric line. Multifocal PVCs are often considered more indicative of there being some kind of underlying cardiac concern. They can be associated with more extensive ventricular irritability and can be seen in disease processes like myocardial infarctions, cardiomyopathy, and severe electrolyte disturbances. And then we have PVC couplets, which consists of 2 consecutive premature ventricular contractions. This phenomenon indicates that we have a higher degree of ventricular irritability. 2 PVCs that happen back to back can either be unifocal or multifocal in nature. PVC couplets can be more symptomatic than we see with single PVCs, and they can be perceived as palpitations by the individual that's experiencing them. What's key here is that if you see 3 or more PVCs in a row, we're not looking at a PVC couplet, we're actually looking at a run of ventricular tachycardia. You may hear terms like bigeminy, trigeminy, and quadgeminy. These terms refer to patterns of premature contractions that occur in relation to the person's normal heartbeats. Starting with bigeminy, this occurs when the normal heartbeat is followed by a premature contraction consistently throughout that 6-second strip. As you can see here, we have a normal beat, PVC, normal beat, PVC, normal beat, PVC, all the way down this strip. In simpler terms, the PVC occurs every second beat. Trigeminy is a pattern where 2 consecutive normal heartbeats are then going to be followed by a premature contraction. In this case, you see 1, 2 normal heartbeats, then a PVC, and then 1, 2 normal heartbeats, and then another PVC. Trigeminy is just a fancy way of saying that there's a PVC every 3rd heartbeat. And lastly, we have quadgeminy, which refers to the pattern of 3 normal heartbeats followed by a PVC. As you can see here, I have normal beat, normal beat, normal beat, PVC, normal beat, normal beat, normal beat, PVC, all the way down our 6-second strip. And again, quadgemini is just a fancy way of saying we're going to see a PVC every 4th heartbeat. Whew, that was a lot of ECG rhythms. As always, if you have any questions, make sure that you leave them down below. I love answering your questions. Head over to nursecheungstore.com. There's a ton of additional resources in order to help you ace those ECG concepts. And as always, I'm going to catch you in the next video. Bye!